I think the speakers are all there. We will start with the program.
Oh, yes, sir. Yes, sir. We can.
Sure. So, good morning, everyone. Today, as you all know, is October 1st, and it's the International Day for the Elderly. And so we thought we will have our Pro Talk CD webinar on this day. And we started this program last year, and we propose to continue this either online or offline every year. First of all, I'd like to thank the management for the support and the encouragement given by our principal for conducting this program. And on behalf of the Department of Prosthodontics, I welcome our principal, Dr. Sharat Ashokan. And on behalf of KSR Institute of Dental Science and Research, I'd like to welcome our speakers for today's program, the senior faculties from other colleges, as well as our college, other faculty members, practitioners, and PG students from other colleges also, and the alumni and interns. I am not going into an official speakers, but because that will be given later. But I wish to welcome and thank both Dr. Kumar and Dr. Anand Kumar for accepting to become the speakers for the CD program. And Dr. Kumar, I have known him, I think maybe from around 2016. They have a wonderful team at Narayana Dental College. Greetings to all of them there. And as far as Dr. Anand Kumar is concerned, he is my batchmate, good friend and advisor also. And I've been knowing him from 1989. And it's a pleasure to have both of you here. Welcome to the program.
Thank you, sir.
And the most important part is that we have two editors-in-chief here. One is Dr. Anand Kumar, who is the editor-in-chief of the Journal of Indian Prosthodontics Society. And the second one is the editor-in-chief for the ISPPD, Dr. Sharat Ashokan, our principal. And I welcome and ask him to say a few words and inaugurate the CD program. Dr. Sharat, please.
Thank you, sir. Firstly, I would like to congratulate the Department of Prosthodontics, the entire team with Dr. Matthew, for organizing this event for the second year in a row. I think it was named Pro Talk last year. And one of our Annamala University alumni, Dr. Prakash, was there. And now I'm happy that Dr. Anand sir has joined. Thank you, Dr. Anand. And Dr. Chalapati Kumar, I think I know him from Narayana Dental College. It's always been another place which I regularly go. Thanks to the speakers for accepting our invitation. And I wish the entire department all the very best. And I would like to inaugurate this program. I'm sure the delegates are going to have a good session with these wonderful speakers. Thank you so much.
Thank you.
Thank you so much, Dr. Sharat. Before we start, there's a special request maybe to the participants. We have already sent you pre-test questions to your email ID. I guess you have got it, and I hope you've responded to that. And it will be open till the first speaker starts off. And we have post-test questions also which are there, which will come to your email along with a feedback form. So please do respond. And some suggestions, if you could please mute yourself during the program and then unmute whenever you want to ask questions. That is, after the speakers have completed, you could unmute and go ahead and you can ask your questions on Zoom chat or the YouTube chat also. That would be better. So we'll have, I will just give you the schedule for today. We will start off with the first speaker. We will start by 10 o'clock and then we will end it somewhere around 11:15. And we will have a short tea break. and then again start with the second speaker. And that will go on maybe till around 12:30 or 12:45. And then we have a small valedictory ceremony, and then we end it. So that's my special request to respond to the questions, as well as to mute and unmute whenever it is required. I'm sure both the topics, Dr. Kumar is going to speak on smile designing, and Dr. Anand Kumar is going to speak on management of failures in fixed partial dentures. So I'm sure it will be very useful to the general practitioners as well as to the PG students and interns, everyone. So I now ask Dr. Biju to introduce the first speaker, Dr. Kumar.
Good morning, everyone. Myself, Dr. Biju, and I'm a senior lecturer from the Department of Prostho. I'm glad to welcome the today's first session speaker, Dr. Hanuman Chalapati Kumar sir, MDS prosthodontist and implantologist. He is a professor of Prostho Department at Narayana Dental College and Hospital, Nellore, Andhra Pradesh. About sir's academic achievements, sir has completed his master's degree from Savitri Dental College, Chennai in the year 2003 to 2006. He is also bearing a post as an EC member in Indian Society for Prosthodontics, Restorative and Periodontics. Sir is also heading a position as a reviewer for the Journal of Interdisciplinary Dentistry. Sir has also authored many national journals and 2 international publications. And apart from an official aspect, sir, you have been my PG external examiner. I don't know you remember me or not. So it has been an immense pleasure for me to welcome you, Dr. Hanuman Chalapati Kumar sir, for the CD program on the topic of smile designing in fixed prosthodontics. So you can take over the session. Thank you.
Okay. So very good morning to all. So thanks for the nice introduction. So before I start, I'd like to thank the entire team of Department of Prosthodontics, KSR Institute of Dental Sciences, and Dr. Sharat Ashokan sir, principal of the institute. Okay, so I'm very glad to be a part of this Pro Talk 2022. And I like to wish Dr. Anand sir. Sir, I'm very much happy to be along share the dais with you, sir.
Thank you so much, Doctor. Same here.
So I've been following your lectures from a long time. I'm sure today also you will be enlightening us with your good talks, sir.
I'm also waiting to listen to your lecture. Thank you so much, Doctor.
Thank you, sir. So just I would like to start my session. So can I start, sir?
Yeah, please go ahead, Dr. Kumar.
Okay.
Yeah.
So today being October 1st, the International Day of Older People or World Elders Day. Okay. On this occasion, the KSR Institute has been organized Pro Talk 2022. So in this regard, I'm going to present the topic smile designing. Okay. So smile design. So smile is the emotion which we show to our fellow people, or when we are happy, which we share with our colleagues or with our family people. So smile is very much important part of our day-to-day life. So this designing of this smile is very much important, being a prosthodontist or being a dentist. So coming to dentistry, now aesthetic dentistry is coming very much important in every part of life. On every practice or in every college, separate department has been set up for aesthetic dentistry, where they concentrate more on designing of smiles or correcting that. Okay. So we can see different expressions or different facial expressions depending on our mind or mood. So among all this, we primarily concentrate smile. Smile is the one which is pleasant and which shows our peace of mind. When we are smiling, lower part of the face, so which shows verbally or non-verbal communication. So that plays an important role. Lower part of the face plays a very important role. So in expressing. So we had to plan or we had to construct proper or perfect smile to create this. So so smile has a positive effect on our mind and body. So whenever when our emotions are good, whenever we are feeling relaxed, so we can present a pleasant smile. If we are under stress, the smile which we give will be tight-lipped or it will look awkward. Okay, so smile has to be a positive effect which shows the presence of mind and the body. So even the simulation of the emotion tends to arouse it in our minds, is this said by Charles Darwin. Okay, so now if we see online shopping or anything, so people are spending lots of money for improving their looks, like in cosmetics. Okay, that can be anyways, and even their looks, they want to improve their looks. Example, bariatric surgeries has been taken a leap because people want to show them this lean and perfect. Okay, so bariatric surgeries and everything have been coming out because people want to show themselves to be a good or appear properly by spending lots of money. Okay, so when coming to dentistry, people come to design their smiles. So we dentists are the architecture of new smile. So when we are constructing a building, we approach an architecture who they plan the building depending on the condition of the soil, the area, and the light, the way, the wind, and the direction. Everything they consider and they design the building. So we as a dentist, when we are creating or when we are designing the smiles, we need to take the consideration of entire unit. Then only it can be appear properly. Means if you design a smile considering only the teeth and the gingiva, that won't be a good. So we need to consider the whole unit. Means entire part of the face has to be taken. So this concept has come forward like facially generated smiles. Means when we are creating smiles, it should be in harmony with the face, not just looking artificially or it looking awkward. Okay, so the recent concept of is unity of the whole. Now coming to smile designing. Smile designing is a process. The process of creating an aesthetic smile based on scientific and artistic guidelines. So we should have, as a dentist or a practitioner or a prosthodontist, we need to have a scientific knowledge as well as some artistic skills. Means when we are finalizing, we should know, we should have a correct application of mind, which is good, which is bad. So artistically, we should design our plan. So these has to be done depending on the previous studies or by perception. Okay, this will be the final result. We need to perceive. Then, and also smile has to be designed according to the culture and racial standards. So for everyone, it should not be same. So smile is a unique one for a particular person. So one smile will not fit to other one, or other person's smile will not be look similar to that other person. So when we are designing a smile, it is like a unity. So a beautiful smile is the integration of these guidelines to make into perfect results. And each smile must take its identity of its own. For example, the beauty lies in the eyes of a beholder. Whoever the person, here we are designing the smile for a patient. We should take consideration of the patient. Come to a point whether those or their specifications can be reachable or not. If everyone want to become some Hollywood star, or if they want to look like a hi-fi cine actor. So they cannot look. So we need to first communicate with the patient, and then we need to see whether their expectations can be reachable or not. Okay, just copying and pasting of whatever there in the books, or in the, when you see in the digital smile designing, whatever there is in the tooth library. So if you cut and paste, that will not give a perfect smile. That will be fake and unaesthetic. So we should apply the rules depending on the subjective, depending on the particular person. Okay, so we need to take his ideas. We need to take entire face as a unit. Then even his personality, even his behavior has to be taken into consideration before designing. So which will give a overall pleasant look. Okay, so if we see the celebrities, so most of them have got it done the cosmetic dentistry done. So to enhance their appearance or smile. Now, so traditionally, initially smile, when they are designing the smile, they used to follow only the orodental complex. They used to see the teeth or the gingiva, lips, that's all. They don't verify other features. But in the modern days, where people want to show themselves like a young or beautiful, so now the entire patient has to be taken into consideration. Entire patient means face, their appearance, their height, their personality, or their behavior. Everything should be considered before you design. So as I said, beauty is in the eye of beholder. So we need to take consideration of the patient. For that, we need to communicate with the patient. First, we should sit along with the patient, communicate with them. Okay, then we need to plan a comprehensive, we need to do a comprehensive examination, come to a diagnosis, and plan the treatment. When you can see here, we can see two generations of BMWs. One is an older version, other one is a maybe recent one. So first of all, if you want to use this one, we need to know how to drive. If we don't know how to drive, if you give a right side vehicle or left side vehicle, it is of no use. We need to know how to drive, and we should follow the traffic rules. Then only our journey will be safe and happy. Similarly, when we are attempting on a patient, first we should know the fundamentals. What should be considered? What should be done to achieve this? Now, for every building or for any architecture, it starts from first brick. Brick by brick it is laid, and the final structure is come. So here also, to design this modern smile, it has a building blocks. These blocks are categorized into facial analysis, lip analysis, pink or white analysis. Pink means gingival analysis and tooth analysis. Coming to face, usually we divide the face into upper half, middle, and lower half. Okay, so middle and lower half has to be in 1:1 ratio. If there is any alteration, okay, so we need to send the patient for orthognathic or orthodontic correction. Then only our result will be good. Then reference lines. When we draw a reference line, it can be horizontal and vertical. We can see here. So reference lines can be horizontal, vertical. Horizontal lines, first line runs between interpupillary line, and other one intercommissure lines. So these two lines must be parallel. And third one is vertical line, which runs at the mid of the face. Okay. So when we are why we need to consider this is, so first thing when we are designing is the identification of position of maxillary central insert. When we are designing, first we need to identify the position of maxillary central insert. So these lines helps in consideration. For example, when we are considering dental midline, it runs between maxillary central insert. That should be in harmony or in close relation to the facial midline. Okay. And incisal plane should be parallel to the interpupillary line or intercommissural line. Then usually parallelism lies between interpupillary and intercommissural lines. Okay. Now, when coming to face, so there will be gross or mild asymmetry between right side and left side. No human will have perfect symmetry. So naturally asymmetry will be there. So there won't be any definitive straight line. So some amount of mild deviation can be there. So here what you have to know is the facial flow. Facial flow is the line when it starts from glabella to the tip of the chin, how it is flowing, whether it is straight, slight deviation. Okay, whichever way it is going. So dental midline has to be in line with that. So if facial midline is like this, if dental midline is like this, it won't suit or it won't be accepted. Okay. Now coming to the profile, what is facial view? Next, profile. When we see profile, we verify nasolabial angle. It is usually 90 to 95 degrees in men and 95 to 115 degrees in women. And E-line. E-line is the one which is important. The line runs from the tip of the nose to the tip of the chin. Usually lower lip will be 0 to 2 mm behind, upper lip will be 2 to 4 mm. So any change in this happens because of change in the profile. In convex patient, where class 2, upper lip will be close to the E-line. In concave, class 3 patient, lower lip will be close. So accordingly, we need to modify our treatment. Then face, shape of the face. As we see in complete denture, when we are selecting the teeth, we follow the shape of the face. Here also we need to consider the shape, but there is one more concept where we need to follow the personality. Means patient is a dynamic personality or is a delicate or is a strong. Depending on the patient personality, we need to check the teeth shape also. Okay, that comes under visagism or visual identity of a smile. Then coming to the lips. So first face we have to see frontal view and proximal view. Sorry, frontal view and profile view. Then lip aesthetics. So in the lips, we see thin lips, medium lips, thick lips. Okay. So females will have voluminous lips or they feel they are attractive. So inverted upper lips convey youthness and attractiveness. Okay, this also depends upon the patient perspective. Then length of the lip. Length of the lip is very important. As I told you, it runs from the base of the nose to the lower part of the upper lip. So the length, depending on the length, the visibility of the teeth and the gingiva. So normally it will be 20 to 22 in women and 22 to 24 in men. So any shorter than this, more teeth will be visible. Longer than this, less incisional visibility. Okay. If we have a longer lip patient, we will have to send the patient for lip lifting. If there is short upper lip, it leads to gummy smile, where most then mobility, how much this lip can be moved upward. This depends on the contraction of the upper lip muscles. Okay. So the amount of lip movement in a full smile is usually considered. Normally lip mobility can be 6 to 8 mm. If it is a hypermobile, where movement of the lip can happen of gum Botox injections. Not only the upper lip, even lower lip should be considered. Here, most important is smile index. The smile index is nothing but the intercommissural width, the line from one commissure to other commissure, if divided by interlabial gap. Depending on that, we can generate beautiful smiles. So usually it is 5 to 7.5. Whereas it is greater than 7.5, it shows an aging of smile. Okay. Gingival aesthetics. So gingiva, So we have seen facial analysis where we need to see frontally, profile view, and lip has to be considered. Then the gingiva. So gingiva architecture. So the contours of gingiva should be proper. For this, we need to do proper periodontal condition has to be healthy. Once the healthy periodontal condition is there, gingiva can remain stable. If not, it leads to recession, or edematous gingiva leads to bleeding or some other secondary problems. Okay, so color stippling and biotype are also essential. We need to identify whether it is a thick gingival type or thin. Okay, so thin means if you don't handle properly, thin gingiva leads to recessions. Okay, then gingival margin. As we see in complete denture, the gingival margin, whether a central insert, lateral canine has to be in same line, whereas lateral it should be lower. And gingival zenith, it is the deepest point of the gingival margin. Okay, so when you are carving, the deepest point will be there on the gingival margin. That is known as gingival zenith. And this is important. Gingival exposure. So most of the people come to us telling most of the gingiva or gummy smile. So which need to be corrected. So okay, gummy smile, when it is told it is a gummy smile, is if it is more than 2 to 3 mm of gingiva is seen, more than 2 to 3 mm. Beyond the teeth, more than 2 to 3 mm of gingiva is seen, it's known as gummy smile. And also papillary height. Lack of papilla leads to triangular spaces. In black triangle spaces also, it will affect the speech, and also it causes aesthetic problems. So dental aesthetics, as I told you, incisal edge position. You need to identify incisal edge position as we do in complete denture by verifying phonetics, okay, like F sounds or E sounds, or by verifying the lip length, we need to identify the incisal edge position vertically as well as labiodental. Then smile arc. If you see here, this is the convex or a positive one. This is a flat or straight one. This is here, we can see an inverted or a reverse one. So positive smile arc is the need of the hour. So whenever you are designing, so upper incisal edges should be in contact with the lower lip. Now, central insert dimension, same. For females, we go with a slender one. For males, we go with a broader, depending on the personality. And this is the most important point. So symmetry between the central maxillary central inserts are more crucial because they are the one which is seen prominently in the lower part of the face. So positioning of the maxillary central insert are important. Then as we go beyond this maxillary central insert, the asymmetry is less noticeable. Then width. So we consider golden proportion. So which is existing in the nature. So maxillary anteriors should be in a golden proportion. This was the theory present previously. But later few studies have said that if you follow exact golden proportion rule, it shows a narrowing of the smile. So later they come with a other proportion known as recurring aesthetic dental proportion proposed by Ward and colleagues. Okay, here in red proportion, they means width by length ratio has to be considered. This also depends on the person's height. So depending on the person height, the incisor height will be selected. Depending on the length of the tooth, width will be calculated. The patient, or the longer the patient, teeth will be long. Same width also should be increased to maintain the ratio between 75 to 80%. So there's a golden proportion. See here, in a short patient, okay, if you follow length, short length teeth will be placed and width also will be minimal. So when we place a short teeth with less width, 80% tooth will be visible. When we see normal patient, When you follow width by length, 70% visibility will be there. Very long, 62. So why it is important is this, everything will be stored in the digital library when you are using a digital app for Smile Designer. Okay. If we know this, then we can select properly. So to which patient which is fine. So if we know the theoretically, then we can select. So one study done by Dr. Shilpa Shetty ma'am et al. In 2011, they told that so this red proportion was not seen in natural teeth. Okay, so previous studies told golden proportion, more than golden proportion, red proportion is better. But few studies they stated red proportion was not seen naturally. So we need to modify our judgment depending on the patient age. For young patient, we need to set some goals. And depending on the sex, if it's a male patient, female patient, and personality and profession, what profession are they doing? Depending on that, we need to modify. In the diastema, the patient comes with a spacing gap and ask us to correct. So we need to judge whether that can be done prosthodontically or need to be done orthodontic correction or any periodontic. So any interdisciplinary approach has to be needed. We need to judge. Okay. So in example, if diastema is midline diastema is more than 4 mm, so better we need to correct it orthodontically. Then only we need to approach. So if more the gap, if we try to give a veneers, and it will be a failure. So we need to correct them depending on the amount of this. Then buccal corridor. Buccal corridor is the gap between commissures and the buccal part of the teeth. Okay. So wider the buccal corridor, that shows narrow dental arch. Then midline already we discussed. So the midline, dental midline should be along the flow with the facial midline. All these things usually we follow in complete denture. So line angles of the tooth, height, contours, embrasures. So how good we need to see, and the color. Usually we prefer lighter color for the female patient, and about the personality and age. Okay. And there was one concept known as visagism. In this visagism, what they tell is when you are selecting the teeth, the personality of the patient and how they want to show in the society, how they want to project themselves. So we need to customize the smile. So you can see here, this is a strong person will have a rectangle face. So we need to select rectangle type of teeth. For a dynamic patient, we have to go for angular or triangular shape. Delicate patient, oval shape. Or calm patient, you need to go for a round or squarish form. So this depends on with the communication with the patient. When you're communicating, if they want to change, they want to show themselves in a different personality, different ways. So we need to modify our teeth shape. Okay. So this everything is there in the teeth library, which we need to select accordingly. Okay. If patient want to be shown like this, so we can show them on the digital screen. So if they like this, then we can convert them into a template, or we can generate a provisional illustration that can be shown to the patient. If they like it, then we can proceed. So by using all these things, before we touch the patient or before we do any irreversible treatment, we can show the patient how their final look is. Now, coming to the digital dentistry. So all these fundamentals are there, right? This has to be put in the digitally in a software or in the app where we need to organize it correctly. Okay? So in digital dentistry has opened the possibility for infinite libraries, tooth shapes, and molds of the teeth. So everything what we discussed, depending on the longer teeth, short teeth, rectangle form, and there is deviation, everything is stored in the library. So patient can select. So patient can choose. So I want this way, that way. And we can visualize before the fabrication and how the final result will be. Okay. So this copy paste concept was developed by Christian Coachman. Mainly he emphasizes that it has to be done as a as good as natural teeth library, not using artificial ones. Okay, so by following the natural ways, we need to select from the tooth library and we need to attach. So we have focused on, right now we have focused on fundamentals of smile design. Okay, students, are you hearing? Hello, students?
Yes, sir.
Okay, what are the basic fundamentals? Can I come to know? So what are the basic fundamentals we have discussed? What are the building blocks we have seen till now? So we have seen facial for analysis, lip analysis, gingiva and tooth analysis. Am I audible to all? Hello.
Yes, sir.
Yes, sir.
Okay.
Yes, sir.
So these fundamentals, once we know the fundamentals, then we need to form a team. So only prosthodontics cannot do everything, because if we want to do any gingival correction, gum line correction, or if we want to do any tooth position correction, we are going to take a periodontist, orthodontist, or if tooth is non-restorable, we have to go for an endodontist. So it is a team. So it is a interdisciplinary dentofacial model or therapeutic model. Okay. Now, what is inside-out approach? Inside-out approach means patient has come to you. Okay, you have taken all the details. Then you plan everything on the paper, or you plan everything on the cast. If you show the cast to the patient cannot visualize, patient cannot assume how it is in the final, or the end result he cannot. So you may be, because you are in dentistry or you know how it is, so you may be visualizing, but patient cannot. Okay, so finally, when it comes out, patient might be thinking something in his mind at the start of the treatment. At the end, when they look in the mirror, it is different. So there is a lot of variation, lot of problems. Now, where in medical field is under attack, where a lot of problems are arising from the patient side or patient relatives, we should take utmost care. Means we need to document, we need to record everything, what is discussed, what is told, even about the treatment plans, about the investigations, about the financial issues, everything need to be discussed. Then only we need to start. Unless they give the consent, we should not start. So planning on the cast or planning on the photograph, it is an inside-out approach. Means we are designing first, then final output is not shown. This is like a puzzle. So if I give only pieces of puzzle and ask you to put together without showing the actual picture you don't know. I gave puzzle pieces. If I ask you to put, we cannot complete it. Maybe we take minutes, hours, we cannot complete. If I show you the picture and if I ask you to arrange them, you know what it is or how it has to be, then you can start it off. Okay. So similarly, if patient or we or the technician come to know how the final result will be, so we can plan properly and end result will be very good. This is called reverse engineering, which is used in the construction. So this Spear and John Coy's that outside in approach. First one is inside out, where we don't know the end result. This is outside in, where we know the end result. This has come forward by the saying of Peter Dawson, who says, if you know where or know where you want to go, getting there is easy. Means if you want to go into one place, we can go. Or if you keep going, if you get into a bus and you don't know the destination, you keep roaming without any stop. Okay, same way, we need to know the final end result, then we can start the point properly. So this approach is termed as EFSB system where aesthetics, function, structure, and biology are put forward. Okay. This is the inside out approach in treatment planning. So in treatment planning, inside out approach and outside in. Inside out, we first do the data collection, treatment. Whereas in outside in approach, after data collection, we get a proposed outcome. Means finally how the patient is going to look, how the patient look or smile is coming out. So we can propose it on the screen, or latest we can generate a virtual image, or we can generate a 3D model. So that can be shown to the patient. If patient is willing, is okay with that, then we can plan our treatment and final outcome is there. So inside out and outside in approach. So here in the Frank sphere concept, even airway is also considered before you start the treatment. Okay. One of the concept is smile designing treatment planning concept. Same, whatever we have seen till now. So everything has put it in a protocol where they term it as SDDP. SDDTP means smile design treatment planning, where we plan properly to achieve smile designing. Okay. So this already we have seen. One is airway analysis. Hello, sir. Hello?
Yes, yeah.
Sir, is it running, sir? Program?
No, one second, just hold on.
Okay.
Sir, I think your screen sharing has stopped, sir.
Oh.
Sir, you can
No,
share your screen, your slides page.
1 second. Now it is seen?
Yes, sir.
Finished?
Yes.
No. Okay. So even airway has to be considered. Means when you are analyzing the arch, narrow arch, we need to correct it so that even buccal corridor where the space between the commissures and the buccal aspect can be created properly. Okay. So if there is a patient is having a sleep apnea or obstructive airway, that has to be corrected. Okay. So before you attempt the smile designing, airway has to be corrected. So next, facial analysis already we have seen, like a frontal view, profile view has to be verified and any corrections need to be done. Then vertical dimension of occlusion. So if patient is having a bruxer where there is a severe attrition of the teeth, so that need to be corrected. Vertical dimension need to be corrected. If not, however good you design and give the prosthesis, finally laminates or zirconia crowns you give, if occlusion is not good, patient will start problem with the TMJ or having a muscular pain. Okay. So vertical dimension need to be corrected. Then when a patient is having TMJ problem, that need to be corrected using a splints or any physiotherapy or anything. We need to correct TMJ problems. Then we need to go with the next level. Then lip analysis, like thickness, mobility, length, dental analysis we have seen, gingival analysis.
Sir, again, your screen has been, screen sharing has been stopped, sir. Yes, sir, it is now. Sir, your audio has been mute, sir.
Doctor, your audio is muted. I think there's a problem with the connectivity, your connectivity. Yeah, now, can you unmute yourself? Yeah,
Now it can be heard, sir.
yes, yeah.
Okay.
You
So
can go ahead.
conclusion, we have to go with any canine guided or group function. This is the virtual treatment phase where we plan our virtually. If you see this table, if patient comes, we create a virtual patient. Like we take a photograph, videos. Recently, facial scans, intraoral scan, everything is taken, and it will be stored in a particular, like a photos means they will be converted to JPEG and stored. Or if it is a scans, that can be converted into STL files, and they will be fed into the software, where using the software tools, we create a 2D plan. Okay, 2D plan can be used by using a PowerPoint and can be shown to the patient. Or we 3D plan, where we can see the teeth and surrounding structures in a 3 dimensions. So using the 3 dimension, this can be sent to the CAD CAM or CAD machine, where it will be sent to the milling machine and generated a 3D model of the arch. Okay, so using that, we can use like a motivational waxer or technical waxer. This motivational waxer can be used to show to the patient, and if any corrections like occlusal correction, gingival correction, any surgery, we can show to them and we can able to convince them. If not, if you tell patient, so because they don't know what is going to happen. So if we show them finally, if you do these corrections, the end result will be this, they can be motivated or they can accept. Then technical waxer, where we can convince or convey our final plan to the technician, and he can do the proper wax, ceramic buildup or any correction. Okay. Yeah. So next. So till now we have seen what is analog or what is the basic rule, fundamentals or basic principles we follow in this from ages. Now, in every industry, as there is an evolution, if we see in the cars or in the telephone, we used to use a hand phone. Next, there is a cordless phone. Now, cell phone. Now it has come to a smartphone. Okay. So as in every industry, there is an evolution. Even in dentistry, we have seen many things like CAD CAM has come. As CAD CAM has come, even in one day, we are giving ceramic crowns or laminates, everything. Okay. And scans, instead of making a conventional impression, we are using intraoral scans to produce the models. Okay. Same way here also, we are entered into a digital smile designing area, where we make use of digital photography, digital videos, everything, and laptop or software applications are used to generate this. Okay. So recently, you might be seeing in your family members or your colleagues, your friends, or so many people who are working in software industry. They are doing the work from their home, means work from home. Because so what they are doing, they can be doing instead of office, they can be same thing they can do in their house. So because everything is there, because the computer or the software or application, everything is there in their hand. So here also, if we have same thing in our hand in the clinic, so everything is there in our hand because it means software, required equipment. So same thing can be showed immediately to the patient and we can start our treatment. Okay. So digital smile designing has been a revolutionary area. So by using this digital smile designing, it allows us for careful analysis of the patient facial and dental characteristics using all the critical factors. So if you don't use this digital smile designing, and if you use an analog or conventional pattern, we may miss some kind of some amount of details of the patient we may overlook or we may miss recording. So that may cause errors in the final treatment. So by using this digital smile designing apps, so we can record entire thing and we can plan and execute. So this has widened the diagnostic visualization, help the restorative team evaluate the limitation and risk factor for a particular patient. If particular patient, this cannot be done, means we can inform them by showing the picture. Okay. Coming to advantages. So what are the major advantages? See, so initially, if you want to book a train ticket, we used to go and stand in line for hours together. Once now, where software has come and mobile is there, we can book our train ticket anytime and we can know the status, whether few seats are there or we are in waiting list. Whereas if we go and stand in the line previously, as we go and reach the counter, they'll tell it is in waiting list. So hours together we are waited and we come to a point where there is a waiting list where we'll be very disappointed. But when we are here using a mobile or software, we can do it or we can know immediately. Same way, diagnosing. When we use digitalization, we can diagnose aesthetically. We can create the smile on the screen and we can diagnose, and any corrections can be planned and executed. Communication. Here, this is the very, very most important point. Unless you communicate. So when a patient comes to you first we need to talk, then we need to communicate with the patient or his attendants properly. So then only we can come to diagnosing and treatment planning. So communication with the patient, and also we can communicate with the technician for the generation of the final end products. And feedback. As I told you, this interdisciplinary, where different branches of dentist are involved. So if any corrections need to be improvised in between, if one step, say you have done the tooth preparation, so next this we need to follow, any correction has to be done to that. So that can be designed on the screen, then can be feedback that can be given to the doctor or to the technician, that can be corrected. So this is a feedback. So constant feedback can be given and for improvisation. And patient management. And this is very important. We can manage the patient by showing them pre-treatment and post-treatment. So pre-treatment, how we are going to live. Post-treatment, how it is. So we can manage the patient. Okay. So managing the patient is important. So by convincing them, by showing them, okay. Then education. So one patient results can be shown to the other patient, means by closing the by masking their face and all. So we can educate the patient, or we can educate the others how the result will be, how the corrections will be. And the customization, as I told you, according to visagism, we need to customize the patient smile according to their personality. Okay? And by using this software, we can double check, and the quality of the final restoration will be very good. And it saves time, material, and cost during the treatment. Limitation. So for anything, there can be advantages and limitations. As I told you, in digital dentistry, most of thing depends on taking a correct photograph, videos, and using a software properly. Okay, for this, we need to know the fundamentals. Next, photography. Photograph means facial photos at rest, smile, videos, everything should be recorded correctly. If you don't record properly, the software cannot do anything. If we do error, even the final result will be big problematic and expensive procedure. We need to procure desktop or laptop. We need to have intraoral scanner, CAD/CAM machine, okay, and software. So all these things, if you want to assemble, it is an expensive procedure. Okay, so this is a costly. That is a very much limitation to this. Then the training. We need to have proper training and handling of the software. Then only we can use it correctly. Requirement, as I told you, we need to have a computer, digital SLR camera or smartphone. Nowadays, even the smartphones like iPhones and the phones where face recognition is there, smartphones can be used along with this app to create the digital smiles. Okay, so recently so many studies have been done where they are using software or software app on the phones to make a correct pictures, correct videos, and other intraoral scanners where they are converted into STL files or fed it into these mobile apps. And even only in the mobile apps, they are creating the smiles or designing the smiles and showing to the patient. Okay, so nowadays smartphones are used in a very much. An intraoral scanner to record maxilla, mandible, as well as in occlusion, and 3D printer to generate 3D models, a CAD/CAM. Okay, so why you require photograph means, so they show as facial as well as, so accurate photography documentation is essential to complete the facial and dental analysis. So on the screen, if you want to analyze properly, correct photography like facial views, dental analysis has to be recorded or done properly on the photograph. Next, see, if you take only static photos, if you take only photos in a static mode, that won't give proper scenario or proper picture, because when we are smiling, when patient smiles, that is depends on the facial expressions, all the muscles, okay, and the movement of the lip and lower part and middle part, everything are involved. So to generate it correctly for that patient, we need to record the videos also. Okay, so there is a study which states that the most important smile which is used to generate the smile designing is spontaneous smile. So when you are happy or when you want to show your happiness, you give a smile. That is a spontaneous smile. This spontaneous smile, if you want to take a photograph, if you ask the patient to sit and give a spontaneous smile, they cannot. Okay, because the spontaneous smile happens only in a millisecond. So to record it, to catch it, so we need to record the smile. If you record the smile, we can run that video, then we can capture that spontaneous smile. Okay. What are the views of the photograph? We have frontal view, profile view, and a 12 o'clock view. Then an intraoral view also. And videos, as I told you, video recording is very, very important. Here, we take a frontal video with the retractor, with and without retractor, while smiling, or profile video with the lip in rest or e-smile. Then the 12 o'clock position. At 12 o'clock, we place the camera and we'll ask the patient to smile, okay, to record the incisal edges, contact of incisal edges to the lower lip. Then intra-occlusal, anterior occlusal videos can also be recorded. So here, photos and videos are taken. Okay, all these are downloaded and inserted into the presentation where we are going to design or which app we are going to use. Static photograph taken at a particular time cannot guarantee the ideal moment captured at the idealistic rest position. As I told you, taking a photograph will not capture the correct spontaneous smile. Okay, so for that, Tarantil et al. They studied a smile on video and observed that average duration of spontaneous smile was 500 milliseconds. It is difficult to record this moment in photograph. Okay, so only in video, if you keep asking, if you ask the patient to talk normally, you keep recording, ask them to smile, keep recording. Then you run the video, whichever way or whichever area you feel it's good, you capture it. Okay. Now, one example of this digital flow. So here, after taking patient photographs and videos, first on the screen, using one of the software on the screen, we draw a lines, one straight line and a horizontal line. Then the patient picture, which is converted to JPEG, is overlap to this line. Okay, here full facial smile with teeth apart. This picture is overlapped such that the facial midline and this screen midline will coincide. Okay, and it is adjusted such that interpupillary line also coincide. So once it is coincided, then we need to analyze the smile. So how the normal smile has to be, or any corrections need to be done. We need to analyze the smile. Okay, study the smile and intraoral picture of the patient. So this is the full face. This is intraoral picture or close by picture. So this picture has to be related. Okay, then we coincide the same lines, midline and horizontal line to the patient picture. As I told you, we need to identify the correct position of the maxillary central insert. For that, we draw 3 lines. One is green line, you see, from canine to canine. Second one is incisal edge to other incisal edge, this central insert. Any deviation is there we can find, and midline. Okay, so this we need to analyze. Same thing can be seen in the intraoral photograph. Next, so after analyzing the teeth, as we discussed earlier, we need to identify the correct size, form, shape of the teeth, right? So we select one of the from the tooth library according to the patient requirement. We can select the tooth and we can overlap onto it. Okay, see that midline is coinciding, and if we select this form of the teeth from the library, that is overlap, then that is okay with the patient. Then we design laterals and canines also. Once this is designed on the screen, next we take a digital caliper. Digital caliper is nothing but it is like a scale, and we measure how much correction has to be done for each tooth, like in a gingival position or the tooth alignment. What correction has to be done, that is recorded, and using that ruler on the diagnostic cast, we are done the marking. See, we are designed on the screen. Same thing has been transferred onto the cast using a digital ruler. See here, this is the gingival level has to be. This is the midline. See here, there need to be correction of central insert and need to be corrected. Here canine, gingival column, cervical line has to be corrected, midline has to be corrected. So everything is planned on the cast. Then when you send to the technician, he will give the wax up. So wax up will be done for the final product. Okay, so once the wax up is done, then we can generate a template or guide can be used on this cast. On this cast, we make a template. Template can be made, then this can be used for a try-in procedure. Or you can make a provisional restoration that can be tried in the patient. So provisional restoration is done, that can be tried in the patient. If patient is happy, and if we leave for a few days or few weeks, patient is happy, then final restoration can be generated, can be routed to the patient. Okay. So here we are shown to the patient on screen, and same thing has been designed on the cast. And finally, the result. So here, this is only a 2-dimensional. So on the screen, it is shown and on the model, seeing that the technician has been designed. So there might be so many errors in this process because what you design, technician might be cannot understand or cannot recognize, or there may be slight alteration, or final result can be a other way, or slight modification might be carried out. So to overcome this, so this is initially this workflow has been followed. Taking a pictures, videos, feeding it into the app, then designing on the screen and conveying to the technician. But there are so many modifications, so many improvisation has taken place where it has shown in the form of generations. Okay, so as we move from one generation to other generation, there will be a, say initially older time they used to go next public transport. Now after that they used to take bikes, now cars. Okay, so there will be a generation changes here also. As we move from in the digital dentistry, Coachman has stated that from generation 1, now we are in a age of generation 6. So we are in a generation 6. In generation 1, what they used to do is they used to take a printed photograph. They used to do the marking on taking a scale or the pencil scale. So everything is marked on the patient photograph and it is shown to the technician and he designed on the cast. Okay, so this is only a 2-dimensional. Generation 1, this is analog drawing over the photos to visualize the treatment result, but that could not be related to the steady model because digital dentistry was not introduced by that time. In generation 1 of smile designing, there is no digital dentistry. Whereas next generation, these photos where digital cameras are come forward and PowerPoint, Microsoft apps have come forward. These photos are fed into the PowerPoint, then you used to design it. Okay, by this they used to save the time. Generation 2, digital 2D drawing are used using a software like PowerPoint, and this steady model was physically connected and they lack the 3D dimension or 3D models. This is the generation 3. The generation 3 is very, very important, where there is a lot of change, a lot of jump in the revolution has taken place. So this was beginning of the digital analog connection. Okay, so this first software specific to digital dentistry was introduced, which here it linked 2-dimensional view to the 3-dimensional vaccine. By generating this 2-dimension, what we planned on the screen can be created on the 3-dimensional way that can be shown to the patient. And generation 4, same 2-dimensional is changed to 3-dimension. So generation 5, where we use mobile phones and we can create a workflow and we can get the final result. Final end view we can see, and this can be fed to the CAD machine or CAM machine where we can generate. So immediately we can get a template, or chair side itself, maybe in few minutes or maybe in an hour or 2, we can get a template or provisional restoration that can be tried in the patient and can show to them. So that is the generation 5. Generation 6, where 4D concept, where facial scan has been converted to 3D animation and smile is generated or smile is created in these 3D models and it is viewed. Okay, motion is added, means rotation, or similar to this concept is similar to the in pictures. When we see the graphics, first they record ideally, then using a analog models or virtual models, they will generate the various expressions or various stunts. So same way here 4D concept has been created. Generation 3, we can see. So whatever is planned, so then and there itself, or we can sent to the CAM machine, and we can get a template, and that can be tried in the patient. In generation 4, facial scan has been taken. We can take patient photograph, intraoral scans, everything are merged, and 3D model can be generated. Okay, so that can be shown to the patient. These are various forms where these are intraorally on the patient, intraoral facial pictures, intraoral pictures, everything are merged and then showed to the patient in final result. Now, as I told you, generation 6, there is a 4D workflow. Here, 4-dimensional workflow. Here, they took photograph, videos in the smile and rest position, in retraction position. They take a photo, patient photos, videos. Then they are taken facial scans also. Okay? Facial scans in different forms, like in a rest position, smiling position. So they used to record the facial scan. Then intraoral scan using a intraoral scanner, using a maxillary arch, mandibular arch, occlusion, everything is scanned. Photos and videos are converted to JPEG. These scans are converted to STL. So all these are stored in cloud storage. Then using a software app, these photos and intraoral scans, facial scans are merged to produce a 2D model or 3D model. Okay, so you can see here different photos of the patient, frontal view, profile view, 12 o'clock view. Then facial scans of the patient. Patient face has been scanned in different ways. Then intraoral scans also be taken. All these things are merged. All these pictures, videos, scans have been merged to produce a 3D waxing. And for this software animation, they fed this to the mesh form. See here, patient face and intraoral designing has been merged together. Okay, so to patient smiling position, how the teeth will be finally look. So everything is merged and it is generated here. Once it is generated on the picture, same thing, 3D analysis or 3D wax up can be done. We can generate a 3D mock-up or design, and on the facial scan, both these things are merged and they generate animated pictures. Means when patients smile with the new teeth alignment or the new teeth positions or new gum lines, how the patient looks in frontally, proximal, profilely, or 12 o'clock. So everything can be checked on the screen using a animated models. Okay. So once it is approved, then we can print the cast and trial registrations are given. Now, we have seen what it is fundamentals and what is digital dentistry. Right. So in the market, if you want to buy a cell phone, there are a number of phones. So which one to buy or which one we can afford, that depends on cost, depending on our purpose. If you want to take photographs, if you want to use for any storage. So depending on that, we select the camera, storage, or depending on specification, we go. So here also in the market, there are a number of digital smile designing softwares are there. For example, there are 13. Initially Photoshop, Microsoft, Smile Designer Pro, Aesthetic, Plan Mecca, so many are there. Visagism Smile, DSD, DSS, Nemo DSD, Exocad, so many are there. So which one to select is depends on our ease of use and the cost, how much effort we can do. Okay, and how good we can transfer this to the CAD machine. So depending on that, we need to select it. Okay. So the factors which helps in this selection of the software is ease of use and for documentation and how much we can afford it and the time. and the digital flow, organization, compatibility, everything should be considered before you buy a software. Okay. So although all the inclusion of aesthetic parameters in different softwares varies, basic procedure of smile designing remains same. So whichever software modality you take, the designing will be similar, or designing end result should be similar, or should be good. Okay. So among these softwares, one study has been done, a study by Doyer et al. He compared 8 softwares to evaluate the digitally how can be modified the aesthetic parameters like facial form, features, dentogingival, dental parameters. So he has verified the 8 softwares, and he concluded that Photoshop, Keynote. So these we see normally in our laptops or in our desktops. For Photoshop and aesthetic design, Photoshop and Keynote softwares and aesthetic design, digital smile design include the largest number of aesthetic analysis parameters. So these 2 softwares have more number of parameters which can be included or designed. Other softwares which are used exclusively for only for digital dentistry or for only smile designing lack few features. Okay. And CERAC SVW is given by the company. PRSD, they work together with the CAD/CAM. So respective company, if you take CERAC SVW, you have to go with the CERAC company name. Okay. Then digital DSD app, which is commonly used. DSD app and Smile Designer Pro were offered as mobile phone application. These 2 apps we can use with our mobile phones also. Okay. Then Visagism Smile and DSD app shared the idea of Visagism. As I told, it depends on personality. Okay. So more recently, ExoCAD has introduced, which can be incorporated to CAD/CAM machines or CAD/CAM features. Okay. So we are seeing the basic fundamentals, and we are seeing when you are designing what all the how to organize them. So next, recently or in past few years, botulinum or Botox injection, where it is commonly used for upliftment of the facial features. So many for TMJ. So many areas it is used, even in smile designing. So even especially when there is patient with gummy smile. When there is a gummy smile where movement of the lip takes place and more amount of gingiva is shown, this hypermobility can be reduced. Okay. So by this, okay. So usually the muscles which involve with the lip elevation are levator, labii, so zygomatics minor, zygomatic major. Okay. So these muscles, these points we need to identify. These points are known as polo points or polo injection points. So we need to identify them. Then correctly we need to inject the Botox solution. Okay. So these, see, you can see here, patient is having a excessive gummy smile. Once after giving the Botox injection in a particular polo injection point, the display can be decreased. But these results happen only after 2 to 5 days, and these results are only temporary. These need to be informed to the patient. Okay. If we give in a small
Doctor, I think Dr. Kumar. Yeah, Dr. Anand, you're able to see us now?
Yeah, I can see you. No, I can see only my slide. 1 minute. Just give me a minute time. I can.
Yeah, now is that
I can see only my face, man.
Okay.
I don't see you. You're not shared your screen. Maybe, but okay, now I can see you.
Yeah,
Now
fine. Okay. Yeah.
now I can see you. So it's audible. Am I audible?
Yeah,
I'm
you are audible. Yeah, you are audible. You are audible.
something wrong with this other
Yeah, I
doctor.
think Dr. Kumar is just joining in. He's joining.
Okay. Thank you, man. Thank you so much.
Yes, Dr. Kumar, can you unmute yourself?
Yeah, sir. So
Yeah,
sorry
yeah.
for the.
No, no problem. No, you can continue. You can continue.
Okay.
Yeah.
Sir, I can't share my screen, sir.
Yeah, we just switched it on now. Just
Yeah.
check out.
Yeah.
Yeah.
Yes.
Yeah, we are able to see the screen.
Yeah, okay, sir.
Yeah, you can go ahead.
Sure. The patient is having a, the listeners, sorry for the net. If there is an excessive gingival display, that way it shows a gummy smile. If you want to correct that one, instead of correcting entire unit, so lip hypermobility of the lip can be temporarily adjusted by using a Botox injections. Okay, but when you're using this, you must be very careful, as it is a neurotoxin. You should give in a safe dose. Then, if patient is having any hypersensitivity to the components, it need to be avoided, and any infection in the injection area, these toxin can cause further systemic conditions and neurological problems. Anything should be contraindicated. And if patient is pregnant, okay, so anything, so we need to, the medication, all the medical history has to be taken into consideration before you use this on the patient. Then complications depends on the bruising. If you don't train yourself, or if you don't have proper knowledge of it, don't touch it. If you go and do any attempt you want, it leads to bruising or tenderness of the injection site, and sometimes it leads to drooping of the upper lip, which may be very much problematic, or patient can sue you. So here, this diastema is there, that has been corrected, and enamel fluorosis that has been corrected. So these corrections has been done as a part of our smile design. Then not only the teeth organizing, teeth identification, gingival condition, or lip, even the luting agent or the restorative material what we are going to use will give a final effect. For example, color. The shade selection is very, very important. If you don't do proper shade selection, whatever design, whatever the plan you have done, will not give correct. For example, patient is having a fluorosis or tetracycline stains, which is not seen now, but if there is a deep stain. So if we give a laminates, where it is a very thin section of ceramic laminates, the stump color or the background color will be seen through the laminate, which will not give final effect. So we need to correctly identify which material has to be selected, whether it is a laminates or all ceramic or zirconia crowns, and depending on the stump size, stump shade, or what effect we need to get, we need to identify the luting agents also. Then coming to implants. So even digital dentistry or this digital software can be used not only to design and also to plan the implants. So if one tooth for a patient, if a single tooth has to go for extraction, we want to, same patient, he is willing for a smile designing. In the same software, after taking photographs and after using the software, we can plan where the implant has to be, or where the next permanent teeth, where it has to be. Then we can plan on the screen. Then accordingly, we can generate a model. Okay. Then a template can be fabricated. Once the template is fabricated, that can be used as a surgical guide for your implant placement. Okay. So same template can be used for correction of adjacent gingival portions also to achieve proper smile. So if you are placing a single implant, we need to check the tooth position, whether the tooth is having a short tooth or longer teeth, whether it is labially placed or palatally placed, and the adjacent tooth position, gingival condition, means biotype, whether it is thick or thin, all the things and everything should be considered, and we need to position the implant to achieve our final result. If you are doing a multiple implants, we need to verify the width of the ridge, soft tissue, and smile line. So all these things can be planned digitally on the software. Okay. So recently, one article was published in Journal of Prosthetic Dentistry, where they merged intraoral scans of edentulous patient. Okay. Then implant position has been scanned. That is converted into 3D model and given to the patient. Provisional restoration has been given to the patient immediately. So this has been done by using a digitalization. See here, they're taking patient pictures, photos, then they scan intraorally using interim complete denture. They scan without denture, and same thing is generated with the facial scans, and they obtained using a CAM machine. They obtained a final process or interim process, and that is tried in the patient and left for a few days or few months. Then patient is happy. That same thing can be converted, or similarly, final restoration can be given. Okay, so this all we can plan on screen, and we can do so that we can save time and we can impart confidence and assurity to the patient. Okay, so by this, I want to conclude. So even though the demand for teeth appearance is increasing, we need to know the technology advancements in restorative material and other ways which will help us in developing or meet the society needs. Okay, so the use of modern digital tools requires adequate knowledge. What main concern is fundamentals about the tooth form and shape principles. We need to know, then only we can take help of software. Without knowing this knowledge, if we go and rely only on the software, we can land up in a big problem. Okay? So, in the durability of aesthetic restoration depends on adherence to the principles of construction. So, each one, step by step, we need to organize, then we need to get the final result. Okay? Digital smile design concept is helpful tool in visualization of the patient problem, and we can communicate and educate the patient. And the choice of this program or choice of which software to be by depends on clinicians training or practice. So depending on that, we need to buy our software and use it for the patient. So take home message. Guys, before you start any of this, first you need to do the case selection. We need to select the case properly through proper communication or proper diagnosis. Then we need to talk to the patient, and documentation is very, very important. So in this, now presently there is so many attacks has been taken place on the doctors or dentists. So because the patient relatives or someone comes, they claim, see, how done this and this. They didn't ask, but you are done. But proper documentation, it can be a photograph or videos. video, whenever you are talking to the patient, everything can be recorded and can be saved, so that when they come back claiming that this is what not we asked, then we can show them. So we already discussed, when we got approval, then only we proceeded. So documentation has to be done. Then consent has to be taken for everything, for any procedure, any planning, everything consent has to be taken. So, and fundamentals, we need to have basic fundamentals of designing the smile, then correct use of latest technologies. All these things put together, we can create beautiful smiles. Hello, students.
Yeah, doctor, is that over, or you are waiting for your questions now?
Yeah, if anyone
Right.
wants any questions, I can.
Right. Yeah. First of all, Dr. Kumar, thank you so much for the excellent presentation. I think you.
Thank you, sir. In between,
yeah.
something has stopped it because of the software.
Yeah, we can't do anything about the technical glitches. We leave it to,
technical glitches.
yeah,
Okay.
we can't do anything about it. But thanks for covering. You touched almost on all the aspects and how smile designing has evolved and gone
Yes, sir.
completely digital. Yeah, it
Yes.
was an excellent presentation. I think there are a few questions. Dr. Mayavraj, can you just read out the questions?
Yes, sir.
Yeah.
So good morning, sir. One question
Yeah,
from
good
Dr. Niranjan Kumar. Either it is inside out or outside in, which is better. The software.
So
Can you hear me, sir?
yeah, I can hear you. We always outside in, because as I discussed, it is like a reversed engineer. Before we start, because for example, when we are planning and executing, we want to do a tooth preparation or gingival correction. Those are irreversible process. For example, tooth position. If you prepare the tooth, that is a irreversible treatment. So if you want to correct later on, that cannot be done. So if you know how to do the preparation, or where to do, or where to modify it, that can be planned ahead by using outside in approach. So outside in approach is better. Then only we can execute correctly.
Thank you, sir. One more question from Dr. Vishnu Priya. In smile designing, which is a better one? Either is a veneering or a full crown, sir?
That Vishnu Priya, I want to let you know. See, veneering or zirconia, that depends on the patient. See, if you want to do a more correction, if there is a deep stains are there, we cannot give laminates. So if there is a minimal correction or minimal modification has to be taken care, then we can select our laminate veneers. If it has to be correct entirely, then we need to do tooth preparation. For example, in case of amelogenesis imperfecta, so in one case has been there, where preparation has to be taken place and zirconia crowns are given. In such case, we cannot go with laminates, because in amelogenesis imperfecta, as we know, enamel is already compromised. In such cases, we cannot depend on adhesive cements for placing laminates. Okay.
Sir, one more question
Is
from
it
Dr.
okay?
Priyanka. Yes, sir. Yes, sir.
Okay.
Thank you, sir. One more question from Dr. Priyanka. How long does the effect of botulinum injection last for, sir?
So the temporary, some study says it hardly there for 2 months or 3 months. That's, I'm not sure. I'll find out that.
Okay, sir. Thank you, sir.
Dr. Kumar, I just had a personal one question from me regarding the app that you're going to use. How easy is it? Because I'm not very tech savvy with the mobile. Is it quite easy to get adapted to it, or?
Sir, recently free software also available, sir, which we can be downloaded in latest mobiles. So that can be used with the free hand, but it needs to take some time, sir, for to get used to it. So how to apply, how to use it. It needs to take some training or some time. It takes some time.
So before you start using, you need some technical training and then go ahead and start using it. Do you have to go for some course or something, or do they give you? Yeah.
That is better, sir. If patient is sitting in chair and if you want to do a trial and error method, that is not a good idea, I think so, sir. Because if you take a prior training, then you can use any software and you can apply correctly.
Right. Thank you, Dr. Kumar.
Thank you, sir.
Any other questions from anyone?
Sir, is there any mobile app which we can get in the Play Store?
In Play Store, exactly. I mean, free apps are there. I don't know it is in Play Store and or an iPhone. I mean, in other app. So free apps are there. Usually DST app is compatible for mobile phones.
Right. Thank you, Dr. Kumar. Any other questions
Thanks,
from
sir.
anyone else? Right, then shall we just take a small break and then get back to the presentation? Maybe just a 10-minute break. We'll just join back at 11:30. Is that okay, Dr. Anand?
It's absolutely okay with me, but it's already 11:27 or 28. So can I join at 11:40 or 11:30?
Yeah, okay, then shall we make it at 11:40? Is that fine?
So anything's okay with me, no problem at all. Thank you.
Okay, then we'll just take a break and then join. Thank you.
Thank you, sir.
Thank you, Dr.
Thank you all
Kumar.
for patience.
Please, thank you
So
so
thank
much.
you. Thank you, sir. Thanks a lot.
You're welcome.
I'll start sharing my screen, check everything is going on smoothly. The organizers are there? Or
Yeah.
yeah.
Yes, Doc.
Matthew, I'll just start sharing the screen and check whether it's working, Matthew, by this.
Sure.
This time. Tell me if there's any issue.
Yeah, we're able to see the presentation.
Right?
Yeah, we're able to see that. You can, just make it as full screen. Just
now is it okay?
Yes.
So I'll just let it be stationed here. Once you tell me, I'll start with my lecture here. Okay.
Okay then. Okay. Yeah. Yeah, Dr. Anand, can we start?
Yes, Dr. Matthew,
Yeah,
can I? Yeah,
just a second. We just will finish off the introduction and then
sure.
go on with
Thank you
it.
so
Yeah.
much.
So I have Dr. Deepika here, senior lecturer. She wants to give an introduction.
Okay, thanks, Dr. Deepika. Make it short and sweet, ma.
A wonderful morning to all present here. I'm glad to introduce the second speaker of the day, Dr. Anand Kumar, MDS, Prosthodontist and Implantologist. Sir is a professor in Sri Ramachandra Institute of Higher Education and Research. Sir was awarded a fellowship in implantology from International Congress of Oral Implantologists in the year 2012. Sir was a vice president of Indian Prosthodontic Society from 2012 to 2013. Sir was a regional country councillor for the Association of Asian Academy of Prosthodontists from 2016 to 2018. Sir was a president of Indian Prosthodontic Society Tamil Nadu and Pondicherry branch from 2019 to 2020. Sir, as a committee member, Council of Prosthodontic Research, Indian Prosthodontic Society from 2018 till date. Sir, as an editor-in-chief for the well-known Journal of Indian Prosthodontic Society from 2021 till date. Sir has authored a number of national and international publications. He has presented various papers in various countries and also conducted hands-on and lectures and also an invited speaker for various state and national forums. Sir is well known for its enthusiastic participations for conducting pre-conference courses and also for conducting rapid review programs. It gives an immense pleasure to welcome you to the CDE program, CDE webinar Pro Talk 2022. Sir, welcome you.
Thank you so much, Doc. Thank you so much. It's
Thank
quite
you.
elaborate. Thank you. Yeah. A warm greetings to you all. So the right trending is this movie, PS, right? Ponniyin Selvan. And the promotion, what's happening. And for the last 1 decade or 10 years or so, this is my profile picture, or this is my laptop picture. All my first slides of any presentation, I have this particular monument. Why I relate this monument to the present PS, because this is constructed by, or this is built by J.M. Ravi, alias Shivaji Ganesan, maybe 50 years before, and 1000 years, actually it was built by Rajaraja Chola. So the entire movie is based on this particular king who ruled for almost 14 years or 15 years, in which he built this monument. Why I have this monument as my first picture in all my presentation? Because the architectural marvelance of this particular building. It's almost 1,100 years or 1,000 years old, slightly more than that. And it is around just few meters short than Qutub Minar. And it's completely of granite. And this entire tower is completely bold. It's a whole inside. It is not constructed. So you can just go inside the sanctum and you can see this rock here. This rock is almost 80 ton, and like the way the movie is promoted, they had a 6 kilometer to 8 kilometer ramp for pushing the rock up. And what is so astonishing about this is this has stood almost, or withstood almost around 6 to 7 earthquakes, so many floods, and still it remains the same. And still we go there, and it's protected by the Archaeological Society of India. Right, I took such a long elaborate because this particular monument was well planned, executed, and even the water irrigation is a forefather of many irrigation systems what's existing right now. That's how the monument has been built. So keeping this in mind, whenever a patient walks into a private practice, right, or when we give a fixed partial denture, all our patients expect our fixed partial denture to stay the way this monument has stood for 1,000 years. And moreover, as a clinician, I'm sorry to interrupt again here. I am addressing a mixed gathering. I was told that there was some alumni, interns, postgraduates, and private practitioners. So I try to balance everything. I'll try to keep everything. More of clinical, bit of literature for the academicians also in my presentation. Now I continue with my presentation. So keeping this in mind, whenever I do a private practice or whenever we talk to a patient for a fixed partial denture, we say we'll give a permanent option to you, and that will stay. I do not understand what a permanent option and what does the literature say for this permanent option with respect to a fixed restoration in prosthodontics. What does the literature say? The literature says that this fixed partial denture, I'm talking about the conventional fixed partial denture, has an expected survival rate of 85% for 15 years if the described clinical and laboratory protocol is applied to the maximum best. And the failure rates for fixed partial dentures were 2%, 7%, and 11% from 1 to 5 years. That means 2% of the entire fixed partial denture fails within the first 5 years, 7% within the 5 to 10 years, and 11% between 10 to 15 years. And there is an increase in significant increase in the failure rate of time. This is what the data provided by this study. So we all assume what we assumed as permanent. The literature says that it doesn't stay. There is definitely some amount of failure rate for fixed partial denture. So one particular literature, 20-year retrospective study, what it says is occurrence of a previously reversible complication is a predictive factor. That means if you see a reversible complication for a fixed partial denture, correct it then and there. Do not wait for the problem to become more worse to rectify later, because if you are going to correct it later, that option may not be available for you. So if you want a good 20-year survival rate, if the patient walks into any time of your treatment with the existing processes, evaluate, give your opinion saying that, yes, there is some issue right now, you have to take care of it. It's up to the patient to decide whether he accepts or not, but you have to tell him. Don't wait, it completely pops out in your hand and finally put a sorry face in front of the patient if it's your process, if you've done the processes, even within first 5 years of time. So it's our job to evaluate for better survival rate. So Gordon J. Christensen has said that it's a well-proven, accepted, routinely used restorations, even in modern present conditions where implant is practiced more effectively. And however, they come loose from the existing abutments for a lot of reasons. We are here to decide, or this entire program is going to discuss on the varied reasons for the process to fail. So my content of the presentation is going to be divided on what is fixed partial denture, objectives, what is failure, signs and symptoms of failure, classification of failure. And we will see in elaborate how to manage these kind of failures when we encounter in our private practice. So as you all know, the glossary definition for the postgraduates, a fixed partial denture that is luted or otherwise securely retained to natural teeth, tooth roots, or a dental implant abutments that furnish the primary support to the processes. The object is what exactly the patient come for. They will come for, normally they say that they don't come for looks if the front is missing. Normally they say that they're not able to eat properly. So basically it will be the aesthetic need, the occlusion, then for the dentist to maintain the arch integrity rest of the life so that there is no unwanted or untoward effect in future. By doing so, we preserve the health and the other remaining structures of the oral cavity. This should be the objective. And if the above is not maintained in the due course of fixed partial denture in the oral cavity, we call that as a failure. So fixed partial denture, when we give, it has to satisfy all the 5 objectives. If one is not failing in due course of time, you have to consider that as a failure. There are many classification systems for enumerating the failures in fixed partial denture. There's one classic article by Dr. V. Chandrakala et al. And this is the link, right? And she has enumerated from 1920 to 2008, the classification given by Tinker, Lombardi et al., Smith, Johnston, and our own John Manapalle. So if you go through this article, you'll have you will find almost on this 8 to 9 classifications. When I went through this classification, what I noticed, all this classification just before John Manapalle, every classification was based only on the failures of the processes. For example, Thayer's classification 1984 was mentioning about failures of fixed restoration due to caries or cementation or periodontal involvement. Likewise, you see the Roberts classification, he also enumerates on cementation failure or gingival irritation. Because of that, there is a failure in fixed partial denture. Likewise, we see Weiss classification, failure of a fixed process due to TMJ disorder or subpontic inflammation. So all these classifications until John Manapalli, right, it's only based on the collection of data with respect to failures. Our gentleman, John Manapalli, he gave a typical lovely classification, which I still fond of, because he classified this failure based on the treatment options provided to the type of failure. He divided into 6 types of failure. Class 1 being just the cementation failure, where the abutment is good, the prosthesis is good. You have to just re-cement it. And class 2, he says that it fails, but without replacing the restoration. But the foundation, the abutment tooth may require some filling also, something like that. You understood? So the prosthesis is good, but the abutment is not good, where you have to repair it. Then class 3, he says the abutment is good, but the restoration, that the prosthesis has to be replaced. If it's a 3-unit bridge, that has to be replaced. If it's going to be a single unit, that has to be replaced, but the abutment will be good. Class 4 is the combination of class 2 and class 3, where you have to modify or rectify the problem with respect to abutment and also change the prosthesis. And class 5, he says that the treatment, if fixed partial denture treatment fails for the patient, but however, you can do one more fixed partial denture. For example, if it's a 3-unit bridge involving 4, 5, and 6, if abutment 6 fails and it goes for extraction, still you have option of additional abutment, and still you can give a fixed partial denture. That's what option 5 says. Option 6 says that you cannot give a fixed partial denture if there's a failure, and you have to think only of an alternate treatment, either with the removable conventional prosthodontics or implant supported prosthodontics. So this John S. Manapalli gives a lovely classification based on the treatment option. So my entire lecture, or what we are going to see, is how to manage these kind of failures under various category, what John Manapalli has put in these 5 subheadings, what I mentioned here: biological failures, mechanical failures, aesthetic failure, psychogenic, and maintenance failure. Biological failures can be again subdivided into 5 subheadings. Biological failure due to the biological hard tissue teeth, which again can be divided into because of caries, because of pulpal damage, because of a fracture root, or an endodontic failure. And if it's going to be periodontal and subpontic and occlusive subpontic, again we will see how we are going to manage that. Change in occlusion due to iatrogenic or due to wear and tear of the tooth, or there's going to be a change in vertical dimension of the patient pre and post treatment by prosthetic rehabilitation. We will see how to manage these kind of flaws. When we give a fixed partial denture and the patient reports back to you and you don't evaluate, or if the patient perceives as a pain, sensitivity, or bad taste or bad breath under a restoration or a loose restoration, then you can make sure that there is something wrong with the abutment or the restoration what you have given. If it's a fractured tooth and discolored tooth, as it's shown in the picture, you will clearly know that, okay, there is some failure. But if the patient says bad taste and bad breath in between posterior fixed partial denture, it's our job to use your floss and see whether there is a food lodgement or make an IOP. Sometimes the IOP may not give a correct picture because the metal will mask what is beneath. So those kind of things you have to be very cautious in evaluation of these kind of issues what the patient says. If it's going to be a dental caries, the issue with the teeth, I'm still with the biologic failure in the teeth. The dental caries may be in the abutment as such, as you see a root caries here, or in the adjacent tooth, or it can be because of root caries as seen in this picture. The causes for dental caries in the abutment may be due to disintegration of cement, seepage of the oral fluids leading to secondary caries, and that will happen only after disintegration of cement. Then the second picture where the process is poorly maintained by the patient. And the poor choice of material can be also one reason for dental caries. In this particular picture, if you see, PMMA resin is used as a veneering material. When a PMMA material is used as a veneering material, the entire tooth has to be covered with a metal coping, right? Normally, we don't use PMMA. PMMA is always considered as a provisional material. It's a lab composite or it's going to be ceramic. So whatever these two, if it's lab composite of ceramic, this has to be completely covered with a metal coping. Otherwise, what will happen? The resin, PMMA resin will imbibe all the fluids from the oral cavity, and the underlying abutment will be spoiled. Unknowingly, when the patient walks back to you, you'll see these kind of issues right now, what is shown in the bottom picture. The one more reason for your teeth failure is going to be poor margin. If you see this here, there's an overhanging margin. It's a two splintered crowns. Normally, as a prosthodontist, we all love to give individual crowns because that gives much better adaptability and comfort to the patient. But we are scared about a lot of other issues like foot lodgement. We go for splintered crowns, and these kind of marginal discrepancies there or overhanging margin is there. We will be in trouble, and there will be secondary caries because of that. The literature also says that the marginal fit can be reported up to 70 microns. This was a old documented when we are using lost salt technique for washing for doing casting procedure. But right now it's digitalized, and most of the printing, most of the core is printed or it's been milled. So this has been much lesser. The errors of marginal misfit is much lesser unless until the technician is not qualified or not good enough in doing a coping, right? And there's one study which actually compares the marginal fit between titanium, cobalt, chromium, stabilized zirconia and your glass ceramic, pure glass ceramic. And all these four did not reveal any significant difference. That means all the four margins are good. That's because of technology, what has been developed so far. So good technology and so good hands, right? You do not come across this marginal discrepancy. And there are a couple of articles to say how to, or latest articles to say that you did not give a finish line lighter, because I came across a couple of discussions or in a forum or seminars where people speak more about this vertical finish line. That means when a vertical tooth preparation, they say vertical tooth preparation, there is no finish line at all. But when I search literature, there is only a couple of articles in non-PubMed indexed and certain articles where it's only a case report. So I'm not aware of, or I'm not sure how this vertical preparation has to stay. In spite of doing good preparations with your chamfer shoulder for so many years, and still we come across marginal deficiency. This vertical preparation, for it to stay in the oral cavity, we have to at least wait for 10 to 15 years to say that okay, this is successful or not. I have my reservations on this type of vertical preparations, and there is no systematic reviews or any meta-analysis on this particular technique of giving a marginal fit. So me, old school of thought, you should have the exact chamfer shoulder and the appropriate diamond points to prepare that. So vertical preparation, if you ask me, I will have reservations. If you want, you take chance on your patients and try. I'll be very happy to learn from you in future if I'm practicing when you're doing a practice. So then after patient's perception, when the patient walks in with dental caries on abutment, it's only through examination, only through visual probing or radiograph. Radiogram sometimes can mask you the issue because you will not know until the exact amount of lesion, what is beneath your superstructure or the core structure. So invariably it has to be through probing or visual, or sometimes even we have to remove the processes to evaluate the abutment. That's quite tricky. The management of your dental caries on an abutment, it's only 3 R's. R1 R stands for remove the processes, restore the tooth. That is John Manopolis class 1 and class 2, class 3 or class 4 also, right? Either remove, re-cement it if it's perfect, or if you want to do some modification, the abutment's damaged and the process is good. So do some modification in the abutment, then cement the existing processes like Manopolis class 2, or change the process alone if the abutment is good, or redo the processes. So 3 R's. Remove processes, restore tooth, and redo the process if necessary for management of dental caries in the abutment tooth. If it can be salvaged, it can be saved. Then the second cause, the other reason for biological failure is going to be the caries in the adjacent tooth. We saw caries in the abutment tooth. Right now we see the caries in the adjacent tooth. The reason for caries can be adjacent tooth is only purely iatrogenic. Still, even a well-established practitioner finds difficult to establish the exact contact between the adjacent tooth. If you ask me, still I find it difficult. It's not easy, right? And you really do not know how much to trim, and you do not know how the lab makes the processes, right? Poor maintenance by the patient is the last thing what I come across. But any correction on the occlusal surface is easy to manage. Any correction on the proximal surface, it's very, very difficult to manage. You have to be extra cautious before cementation if you're going to touch the proximal surface. Once you fix the crown in the oral cavity, you have to make sure that the floss enters the oral, the interdental area with tight. You have to have some resistance. If there is no resistance, if easily it goes, that means you are going to make money on the same patient after 5 years treating the adjacent tooth, right? We are not here for doing that. We have to be so genuine and make sure that the proximal contact is maintained. It's purely iatrogenic. So there are a couple of articles which says about proximal contact, and there's one article by KSRIDSR et al. And he says that you have to adjust it adjacent to proximal contact sometimes to create a proper embrasure. Normally we don't do that, right? We just prepare the tooth and do it, and we really do not know what is the proper proximal contact. So you have to know the exact configuration of the adjacent tooth. It can be different for molar, premolar, and canine. Whatever it may be, you have to know the contour of the proximal contacts. Try to maintain the best proximal contact. If you have to manage that before you make final impression of the prepared tooth. I'm talking about adjacent tooth. Otherwise, till then you don't do it. And there's one article in a Pakistani journal where it says that they evaluated the proximal contact after cementation, and they found only around 58% were acceptable, right? Proximal contacts, 30% were quite loose, right? And it's not a good sign. So when you just cannot say that since they are Pakistanis, we are doing like that. But most of the countries, when you really do it, it's going to happen. So you really have to keep an eye on this for managing the proximal contact. This is one article by Dr. Goel et al. He talks about proximal contact in the posterior teeth and the factors influencing about it. And this particular case report by Dr. Daniel, he says how to manage or how to prepare your crown without damaging the adjacent tooth. Sometimes when we prepare the proximal side of any tooth, we tend to practice, or we tend to damage adjacent tooth. So you have to be quite cautious in preparing, right? You just cannot take for granted and blindly be proud in saying that I finished my preparations in 3 or 4 minutes. It's something like a surgical procedure where you are doing a hard tissue surgery where you prepare the tooth. That's almost equal to a surgery, because when you cut an enamel, you're not going to get it back. So when you cut an enamel for the adjacent tooth, you're not going to get it back. If accidentally you touch it, you have to smoothen it before making an impression. Otherwise, this particular Daniel Kim et al. gives a clinical case report to say how to prevent damaging the adjacent tooth while doing preparation. Then, as I mentioned before, you have to do a proper filling. If this is just a class 2 filling, and see the margin. This is how a margin is supposed to be. It should follow the contour of the tooth. Whenever you do a process, make sure that you re-establish the proximal contact and make sure that teach the proper maintenance protocol to the patient. Then the third biological failure caries is going to be. Am I audible? Or anything wrong?
You are audible, Dr. Anand. You are audible.
Okay, sir. I thought some disturbance. That's okay. So fine. So the third part is going to be caries, root caries. First we saw the caries on the tooth, of the abutment tooth. Second was caries on the adjacent tooth. Now the root caries. The root caries, again, the main reason is marginal breakage, then poor contact with the adjacent tooth. What is again iatrogenic, where we fail to manage. And third can be gingival recession and pocket formation. This also may be because of us, we don't give a proximal contact, we don't maintain the, or we don't give an opportunity for the patient to maintain the health of the periodontium, right? So there will be gingival recession, or if the patient itself does not manage properly, he's going to have gingival recession. And there are certain medical or situations where patient can come with drug-induced decreased salivary flow, and all these things can lead to root caries. If there's a root caries, again, the only solution is 3 R's. Remove the prosthesis, complete treatment on the caries tooth. If you have to do a root canal treatment, do a root canal treatment and redo the process. When you redo this processes, make sure that the margin is on the natural tooth. The margin should not be on the restoration. So whenever you're doing a restoration, it's our job to make sure that the restoration lies only on the natural tooth rather than the restoration. In this picture, if I'm going to restore this root caries here with some filling material, I'll make sure that my margin is somewhere here beneath it, maybe a knife edge with the burnishable material, right? So that the harmony is maintained. So Greg Libby et al. Says that dental caries is the primary cause for failure of fixed partial dentures, but specific radiograph, clinical and laboratory procedures can increase the length of service of this restoration. That means it's not our job to fill a pocket after fixing a fixed partial denture in the patient's mouth. You have to make sure that the patient comes every year to you, or once in 6 months. I'd say once in a year is okay, right, to you, and you make specific radiographs, evaluate them, make sure that this whatever problem present that time has to be addressed. Otherwise, you end up in a lot of difficulties where we have to, you understood, we cannot take things for granted from here. The second type of biological failure is going to be pulpal failure, and pulpal failure can be immediate or delayed pulpal failure. The causes for immediate or delayed pulpal failure is going to be excessive preparation of the abutment, extreme temperatures, and dehydration of the teeth. So to prevent pulpal damage, you have to have an optimal preparation. And I still wonder what an optimal preparation is, because when you say the textbook says that you have to finish the preparation only on the enamel, right? And all the textbooks, most of the textbooks, then we were reading right now, at least we have our textbooks with Indian authors. When we are reading, the only foreign authors, Europeans, and their tooth are more bulbous. The enamel itself will be around 3 millimeters thick. So when they prepare the tooth, it will be still enamel. But when we just run our diamond point twice around the tooth, we are the dentin. So optimal preparation is obviously it's going to be dentin on Indian population, but it has to be optimal. When I say it has to follow the textbook preparation guidelines, you have to have your functional cusp bevel and the finished lines. Do optimal preparation. I'm not here to take class on that, but refer a textbook for how to do an optimal preparation. And one such article by Dr. Neelam Sharma in our own journal way back in 2007, right? She has mentioned about the clinical tips for full mouth rehabilitation, how to manage a good preparation. Yeah. Then prevention of pulpal damage. So normally when we use diamond point and narrow trampage, I normally see this kind of water flushing through a small nozzle to clean the abrasive agent. Right, here's a diamond point. And if you see the first picture, the water sprays somewhere else, right? That means the water may be on the abutment tooth or may not be on the abutment tooth, but the debris of the prepared tooth will be clogged into the between diamond particles. If that is clogged, that means the cutting efficiency of a diamond point is not effective. So you have to a good handpiece which exactly projects the water targets around the diamond point, where it cleans all the clogged debris. At the same time, it cools down the tooth. So if you are going to do that for a good tooth preparation, you need not worry more about it, right? So make sure that the handpiece is very good. And second is your provisional restoration. A lot of private practitioners say that I do the preparation morning and next day morning my technician leaves, but one night the patient stays at home, right? There are people who give crowns in final processes in one day. That's well and good. You prepare in the morning, your lab facility, you print zirconia or a metal ceramic, right? And even then zirconia, they sinter it for almost 8 hours. I don't know how the patient waits, right? Even then there are the sintered zirconia, people do it and we can sim it within 4 or 5 hours on the day. But if you are sending the patient after preparation, even for a day without a crown, provisional restoration, that means you are in trouble. The patient, you do not know what type of damage. Even a small growth of your soft tissue or a finished line will damage your final processes. So make sure that you do a tooth preparation. And the umpteen number of articles since 1970 to say that you have to have a provisional restoration. And one such article, what it says is you have to have sufficient water. And that author also says that do not continuously keep pressing or standing on the handpiece foot control. He says every 20 seconds, you just give a break. Normally don't do it, but that's what the author prescribes. right? And he also says that in the vital tooth preparation, you have to have a cooling technique, otherwise don't do it. Even if you do a putty index for provisional, so when you make a putty impression for provisional, he says do not just overcool it or do not just keep it hot so that it damages your prepared abutment. And if you see a delayed pulpal damage or a pulpal damage after cementation, normally what we do is, because if it just cemented a month back and you do not spend money from the pocket, because if you have to remove these processes, either you will damage the tooth or you damage the processor, then that means the lab will charge you more. So normally what we do, you just gain access through the occlusal surface, complete the root canal treatment. This can be done only on an emergency or only on a temporary basis. This is not the recommended way of managing irreversible pulpal damage after cementation of a crown. Normally, if the situation arises, what I do is I remove the processes, do a root canal treatment. Then, if the processes is undamaged, I cement the same or I repeat the process. So this is how we manage. The third issue is your fractured tooth, and causes for root fracture is going to be endodontically treated tooth without a post, right? So what is your take on endodontically treated tooth, whether it should be given, first of all, whether it should be given a crown or not? So if it's a very difficult situation, and it all goes with your clinical knowledge. If endodontically treated tooth, if it's not, I'm talking only the anterior tooth, I'm not talking the posterior tooth. If endodontically treated anterior tooth, right, walks into your private practice or walks into a clinic referred from endodontic department for a crown, you have to evaluate the tooth, see whether it's discolored, see the number of walls damaged on the anterior tooth. If no such walls are damaged, or it's very minimal damage to the remaining natural tooth and it's not discolored, my treatment of choice is only a post and core, fiber post and core. I will not even try to give a crown, right? But at the same time, you have to make sure that the occlusion is taken care of. When I say occlusion, that particular root treated tooth, what you're going to treat with post and core, should not take the maximum load when the patient during a dynamic or static occlusion. It should be shared, right? If that's the situation, I do not do a post and I do not do a crown for anterior if it's not discolored and less of tooth damage. However, see, if you are going to prepare, what's going to happen? The neck is going to become much lesser. The chance of fracture is more. So in endodontically treated anterior tooth, if you're going to give crown or not, I prefer to go with a post, fiber post, then a crown. If need not, if it doesn't need any change because of color, you stay with your post alone. Then, what is literature with respect to this? It says that crowns on non-vital tooth fail more than the vital tooth, and anterior tooth fails more than the posterior vital tooth. So this is a good learning lesson for us. So there are supporting documents to say that the vital tooth fails, non-vital tooth fails. So there are a lot of, again, private practitioners. They are the school of thought that if you want to do a fixed partial denture, you have to first thought in the mind is do a root canal treatment so that I'm happy. The patient does not come with sensitivity or pain, and give a 3-unit or fixed 3-unit or even anything more than that fixed partial denture, right? Not so. That means if you're doing a fixed partial denture on intentionally doing an RCT for no reason, the teeth will fail soon. The life of the abutment and life of the processes becomes reduced to half. So keep that in mind. Then why there should be a loss of the abutment because of in a root treated tooth? Because there is loss of moisture, and there are architectural changes due to collagen alteration. And all this literature are given in, all this data is given in this literature. And it says that there's 9% less of moisture in pulpless teeth and 14% reduction in strength. And moreover, the endodontic teeth reduces in stiffness by more than 5%. And if it's a MOD preparation, 60% of the reduction is gone. So there is no structure at all. So keeping all these things in mind, you try not to devitalize the tooth. And not all root canal treated to anterior fail, but you have to take occlusion to consideration, as I mentioned before. So endodontic treated tooth, if they walks into you, it's your job or it's our job to analyze whether you have to go for a crown or just stop with post and core and manage occlusion. And the other cause for fracture of anterior tooth or excessive tooth preparation, invariably it happens in the mandibular anteriors. This is quite bulbous. There are a couple of preparations where you cannot even give a proper finish line. It will be only like two thin safety pins standing in the oral cavity on which you have to give a crown. If it's a root canal treated, then it's gone for you. That also is not there. So those kind of crowns, when you try to forcibly cement it, it will fracture. You have to be quite cautious. Then interfering eccentric centric contacts. When whatever processes you are going to cement, you make sure that patient should have a mutually protected occlusion. That means when the patient bites, the posterior should protect the anterior. There should not be any contact at all in the anteriors. When the patient guides the mandible, the canine should contact, or it should be a group function occlusion where all the posteriors along with canine also guides the mandible. If you do not have these kind of mutually protected and ideal dynamic occlusion, as I mentioned right now, canine guided or group function, you will have interfering centric contact that will eventually fail you the processes what you are given, and do not forcibly try to sit in process. That will also lead to fracture. So if it's a fractured tooth, how do you manage? We all know it's going to be only through post and core, and let us not go more into detail about post and core because your endodontic books talks more about post and cores. And the only criteria what makes us to decide between a rigid and non-rigid post, these the 3 points what I have given. What it says is rigid posts are choice for teeth with less than 3 to 4 millimeter vertical height or less than 25% of tooth structure. So that means if you're less than 25% of tooth structure, you have to go for a cast post. If you're not able to manage through your fiber post, right? Otherwise, you can have a non-rigid fiber post between 25 and 50% of tooth structures there. So between 25 and 50%, you can just stay with a fiber post, because still you have the core material to prepare the tooth and give a crown over that. But if you have more than 50% of tooth structure, depending upon the occlusion, either you go for a crown or just stop with your good composite build-up. The aesthetic is not of great value to this particular patient, or if you can manage aesthetics. So when you prepare a post, you should have a good armamentarium for making impressions. I do not know still how many people have their lentillos in the private practice. I'm sure how many people will heard about lentillos also. Lentillos is one of the good gadget to push your cement or push your impression material into the prepared radicular space for making impression. So have a proper armamentarium, and when you make a good impression, the impression should mimic like this. The entire the prepared radicular space has been recorded, and the final product also will look like this, almost mimicking the next replica. So you have to cement it, make sure that you have a good ferrule effect, and then you can give a crown over that. Then if it's more than 50% of tooth is here the tooth number 1 is vital, tooth number 1, 2 is non-vital, in which both are not discolored. So after endodontic management, radicular space is prepared, a composite build-up after with the proper protocol, and well-finished composite restoration with proper occlusal management will last like this for many years. You did not even go for a crown. You can go for a crown when the patient walks in with a discolored tooth, maybe after 5-6 years. That time you take a call whether to again go for a composite or a crown. Try to keep the treatment as simple as possible. Try to make the nativity of the patient. Try to maintain what is there, rather than you giving something new, and that's going to get a lot of, it's only beginning of a trouble. Then the next issue is fractured root. If there's a fractured root, nothing can be done. How does the patient perceive? The patient perceive as it's a loose restoration, or they'll have the restoration in the hand. So the reason for it is going to be improperly designed post. If you see this particular picture here, see the post, how thin it is and how core, and see the thickness of the core. And I don't see any ferrule effect at all here. It's just going to be like the olden times of Richmond crown. At least Richmond crown has some amount of ferrule effect. And this kind of poorly designed or improperly designed post, or poor fit of the post, will definitely lead to fracture of your root as such. And there are a lot of articles to reinforce saying that the role of ferrule in maintaining the integrity. So I believe in a positive ferrule effect. If there's no ferrule effect, I think 100 times to cement or lute a post. One such article with John S. Mamoon, what he says is how this ferrule effect induces biomechanical stability with different types of post and cores. And there's one article which says the length of your ferrule, how does it affect your post and core, the longevity of your abutment as such. The one more reason for your fracture of the root is going to be a decreased neural effect. When I say decreased neural effect, what happens is root treated tooth has much lesser sensation than your vital tooth, right? The patient do not know what type of how much amount of force is going to impart onto the tooth. For example, if I just going to take something on a vital central says this vital central says the patient will have pain. But if the patient would bite the same food, or imagine it's a carrot, right? If the patient would take the same carrot and bite in the root treated lateral incisor, he will not have pain unless until the tooth fractures. So that means the patient has decreased neural sensation. That will lead to unwanted load because there's no pain perception of the patient. It will lead to failure. So you have to be quite cautious in dealing with this root treated tooth. Inform the patient that be cautious while eating, not to bite anything rest of the life, because they think that once root treated tooth is given and your high end of 20-year or 30-year guaranteed zirconia is given to them, they think that it's stay rest of their life. And the lab is also quite smart now. They'll give only guarantee for the processes rather than the tooth, right? And you cannot put a sorry face in front of the patient with the warranty card. So management of root fracture is, if it can be utilized further for gaining some ferrule effect, you can do a post and core followed with a crown. Otherwise, you have to do a retreatment, remove the fractured root, refabricate a processes with the new design like implant processes or additional abutment and finish the treatment. Then the last failures in tooth is going to be endodontic failure, and endodontic failure can be just because of endodontics, maybe the root perforation or inadequate endodontics. Most likely, if you do it, you will know. But if the other department does in the institute, you may not even know. So you have to evaluate the IOPs or the other related investigatory procedures to check whether everything is perfect before you proceed. Then again, it says that there's a literature review to say that endodontically treated teeth are not good for your fixed partial tension crowns, as I mentioned earlier. And if there's an endodontic failure and if you can save the tooth, you can actually do a retreatment, use that as an abutment. If you feel that it cannot be used as an abutment, the longevity is going to be poor, just remove the tooth and redesign. The next biological failure is going to be a periodontal failure. The causes for periodontal failure is going to be poor margins. I'm sure everybody, all prosthodontists, all practitioners is going to come across this kind of situation. The left picture is going to be a metal ceramic, right is going to be your metal free or a zirconia. But if you come across these kind of margins or even a minute gap like this can lead to periodontal failures later stage. Or we are not bothered about over-contoured restorations. Over-contoured restorations like this bulbous, see the entire oral cavity, bulbous restoration, where the foot flow, normal foot flow pattern is affected, right? This can lead to poor oral hygiene and such damaging periodontal tissues to the patient. So again, there are manuscripts to say that the surface roughness, marginal fit and contour of your processes plays a vital role in maintaining the health of your periodontium. And this particular article by a systematic review, which also says that how the process stays after the axial contour alteration restorative treatment. The third cause for your periodontal failure is going to be altered biomechanics. See in this particular picture, leave your Antis law. See that 8 is supported, and I think only opposite central and lateral are 1, 2, and 1, 3 is taken. No wonder. So 1, 1, 2, and 2 is taken as support, and the molar is taken support. See the number of pontics there. Right. And imagine for this patient, there's no posteriors also. He's going to bite only with the anteriors, and there's going to be altered biomechanics. And obviously, the periodontium is going to be much weaker in the 2 abutments. So do not do like this kind of preparations. Manage your biomechanics properly. One more reason is going to be your rough surface. This is again lab composite. This is not even acrylic. A lab composite leading to such kind of periodontal damage to the in the abutment area. So these kind of rough surface and lab composite which cannot give as good as your ceramic, right? Nowadays it comes as good, but certain patient cannot tolerate this kind of damage also, this kind of irregularities also. So be quite cautious in using processes with rough surface. Then the treatment for that is maintenance of periodontal, remove the processes, do a good periodontal therapy, right? Once it completely heals, redo the treatment and make sure that you don't come across with these kind of issues later. You call the patient periodically, make sure that he maintains properly, and that's it. Then the third biological failure is going to be subpontic inflammation. And the main reason for subpontic inflammation is going to be your pure pressure on pontic because of our provisionals or the because of the provisionals or the final processes what you're going to give, or the pontic connecting two large areas. So we normally don't practice what the different types of pontics design what's given in the textbook. We normally just go with what the technician says. But once you, this is a particular picture where the provisional is removed and see the excessive pontic has given subpontic inflammation. So it's our job to make sure that this kind of damage is not induced by the operator. And the other cause is improper cementation. The top picture is because of cementation using your zinc oxide regional cement on a provisional restoration. The bottom picture is using your self-cure acrylic resin as a cement and PMA material cement for the crown to stay in the oral cavity. These are all documented pictures, right? So we cannot even do all these kind of things in the private practice or in a college or wherever you practice. You are going to encounter with subpontic inflammation. And see this particular picture on the right side. This picture, patient walked in after for lower processes and he said they want to change the upper process. Then on history, it was done almost 10 years before. When we removed, see the amount of glass and cement present on subpontic lesion. Not even removed 10 years before, still stayed like that. So these kind of things or these kind of issues will definitely lead to subpontic inflammation. Again, one more reason for subpontic inflammation is going to be poor maintenance of the patient. And as I mentioned before, it's mostly iatrogenic and you have to be quite cautious and removing this excess cement even after provisionals and final restoration. Next is going to be the occlusal failure. When I meant failure because of occlusal interference. The interference can be long-term or short-term interference. When I say short-term, the patient comes to immediately cement a fixed partial denture and or a single crown. And if you fail to notice the interference or the patient adapts the interference what you are given, right, initially, and comes back to you within quite short period, the short term, and the patient will perceive as a discomfort or pain. And if IOP or other investigation says that it's going to be irreversible pulpal damage, you remove it, remove the processes, do the treatment for the abutment, then redo the entire process once again and cement it or manage the occlusal surface of the processes and cement again. On long-term cementation, something like this particular patient gave this, a 3-unit process was given almost around 20-25 years before. In due course of time, patient lost the posterior teeth and the patient was eating only with the anterior teeth. And see, if you see here, the IOP on the top here, see the periapical lesions on the abutments. And there is no posterior teeth of the patient was eating only with the anteriors. And on removal of this, I'm sorry. Am I there? Am I
Yes,
there?
yeah. Yes, you're there.
Yeah. So these kind of things, what you're supposed to do is, if it's an irreversible damage, you have to remove the processes, remove the interference, cement the processes after correction of occlusion. For this particular patient, we have to rehabilitate the posteriors, make sure that the posterior eats with the patient eats with the posterior teeth. Then you rectify the abutments if it's damaged, then redo the processes. Without correction of occlusal surface or the posterior occluding units, do not even touch this patient by only doing the anteriors, because again, you're going to worsen the situation in future. Then long-term interference, you can encounter something like this patient walked in without any pain. Right? Imagine the patient with provisionals, not even come for final processes, right? And the entire labial surface of the root is seen. Nothing can be done. You can only remove the failed abutment and redo the process. Some other alternative, maybe an implant or maybe fixed denture with alternative abutments. Then I just want you to see this video. I'm sorry, 1 minute. This is again, one patient of mine. In this video, the patient is trying to close her mouth, right? So this video, the patient is trying to close her mouth. When she walked in, maybe around 7 years, she was with this processes given by dentists elsewhere. And when on evaluation, it's found only the posterior molars were in contact. Both sides, the posteriors were adjusted along with the canine, one of the canines, and the occlusion was not managed. Patient walked in like an old person, body bent and with tremors in hand, jaw was not coordinated well, jaw was shivering actually, and she was on antipsychotic drugs because nobody was able to understand what the issue could be. She had a lot of MRIs in hand. Finally, when she came for something, I think she came for a removal of this particular fracture process. Then when we evaluated and we just saw this and we removed the processes and called her for evaluation after a week, she walked in boldly and she said, "Doctor, all my problems are gone. I'm happy right now. I'm able to cut vegetables. Last 7 years, people were telling me that I am something wrong with my mind and I've taken antipsychotic drugs." Such kind of psychological changes can lead to patient if you don't manage occlusion. You understood? So occlusion has to be taken care very well. Otherwise, you end up in irreversible damages like this. And changes in VD, I'm not going to much into changes in VD because it's again a separate topic by itself, where it's going to be an occlusal rehabilitation. So the causes of increased VD after processes is just going to be you giving a 3-unit bridge, slightly increasing in height without managing the prescribed protocol of your occlusal rehabilitation, either following Hobos technique or Pankman. I'm talking about the well-established Hobos or Pankman. You just try to do something and you end up in trouble. And sometimes you come across rare of restoration also, decreasing VD after crown. Imagine this particular patient, young patient, the metal restoration, the posteriors, the metal restoration worn out, even the natural teeth worn out. So these kind of restorations, it's again occlusal management where you have to be quite cautious and following all the 7 steps of occlusal rehabilitation, starting from initial assessment to final fabrication of definitive restoration, either by Pankman-Schuler or Hobos technique. Now we come to the second type of failure, the mechanical failure. Mechanical failure can be due to the cementation failure. That's because of inadequate preparation of the tooth. So if the tooth is not prepared properly, there's going to be cementation failure. Or if your casting is not fitting properly, you will have a cementation failure. And if you have an occlusal mismanagement like this, again, you can come across cementation failure before going into the other types of failure. And an excessive load on the cantilever portion of the bridge. Here, if you see on the patient's right side, the cantilever starts from the canine to the second molar. So if there's going to be excessive load there will be cementation failure on these kind of cases. And by us, incorrect manipulation of luting agents, we supposed to use the same scoop and the guidelines given by the manufacturer of a luting cement. We normally take 1 scoop, what we use for polycarboxylate, GAC for polycarboxylate, mismanage the powder liquid ratio. So if you don't manipulate, that also will lead to cementation failure. When the process comes, then before cementation, I just want to insist certain things. You have to, I just brush through this bit faster because we are, I think, another 15 more minutes, Doc, or take 20 minutes.
Yes, you can continue, Dr. Anand. You can.
You tell me, if you just give me last 5 minutes so that I rush from there. I don't want to rush from here because I started seeing the time. Now it's almost just 10 more minutes from a stipulated time. That's why.
No, you can continue. You can
just tell me 5 minutes before. Otherwise, I'll finish much before. Okay, thank you, Dr. Matthew. So I insist on certain aspects when the processes are sent to you from the lab. How many people have the habit of opening the process much in advance? Normally, what we do, the patient sits in, we open and see. You're not supposed to do that. You have to see as soon as it's received, you are received from the patients, from the lab assistant or somebody, or the delivery boys, because you have to evaluate the processes. There can be a lot of things. The delivery boy could have dropped these processes down or along with the box is given, right? There can be some fracture line going on the ceramic. When you try to evaluate, push the ceramic inside the abutment, it can exaggerate and it can lead to fracture. Right. If you see this particular picture here, there is a fracture line here. Right. And this is actually fracture. And if you see here, see the interdental area. You're not supposed to receive something like this. If you're going to receive something like this, then that means you're going to have accumulation of food particles here. And again, you will not know. Patient will come back to you after cementation. Right? Rather, you find it now itself that the problem and rectify, send to the lab immediately. So evaluate the process once it comes from the lab before the patient arrives. Then you have to evaluate the intact surface. Sometimes you do a metal ceramic. Right now you have pressables, and now right now you have your what do you call monoliths. Fine. When you do a veneering ceramic, there can be perforations on the core material. This is a core material where your nickel chromium was used that time. I think it's a nickel chromium crown where you can see a perforation on the nickel chromium, and the technician has completely masked with your layering ceramic. Normally, it will not be seen outside. You have to see in the transparent light. If you see in the light, if light passes through, that means there's a perforation on the metal, and you try to manage with the ceramic. And if you see the picture on the left side, you can see the spicules of ceramic here, spilt over ceramics here. If this is there, you have to remove before cementation. If you're not going to remove this before cementation, your fit will not be good. You will not know what's going wrong. So check all these things before the technician leaves the dental practice after giving these processes to you. Then fit in the model may not be same as the fit in the patient's mouth. We normally blame the technicians. I don't say I blame the technician. Many times I take the blame myself. Right. Sometimes if it's good in the cast, if it's not fitting in the oral cavity, that means it's not the technician's problem. It's our problem. There are very few situations where the technician's mistake will be there if it fits in the cast and doesn't fit in the oral cavity. Most of the time it is going to be us. So very cautious. Let's not blame the technician and rather try to find why the failure is because of us. And impression procedures, you have to have good techniques for making impressions. Normally what we use is your stock trays, your custom-made trays, or triple trays, and each has one indication. Whenever you make a putty wash impression, this particular impression technique is two-stage impression. What normally we do, we make a putty impression, then do we cut all the, or when we make a putty impression, I doubt how many people will keep a spacer. Because most of the private practice or most of the colleges where I visit, or even my institute where I see, nobody has done us keep a spacer before they make an impression. Right? If they make an impression and if the second impression is like this, I will not say anything. If they make a spacer and while doing putty and relining with secondary, if it's coming like this, I will not say anything. But a secondary impression without spacer, if it's like this, that means you're not control the pressure properly by loading the tray second time into the oral cavity. That means you've done blunders. It looks perfect, but it's not perfect, because when you made the first impression, all these red color or the brown color things was exposed. Right now, you're supposed to only reline it. This doesn't look relining. You're just completely overlaid with some of the new material. This will definitely lead to a lot of issues when you make, when the process comes to you. If you see here again, the same lower impression, it's a metal exposure, right? There's a metal exposure. That means again something wrong with the impression. You cannot have these kind of errors in your stock or your custom-made tray. And when you use a triple tray, be quite cautious. Triple trays, you cannot bend it. You cannot add backs to something and make an impression. And normally, when you make a triple tray, it's limited use, right? I use triple tray impression only for maximum up to 3-unit bridge or a single crown. If it's a 3-unit bridge, there's something called as tripodization, right? I should have a good natural tooth in occlusion beyond my terminal abutment. When I say this, I'll give an example. If I'm going to prepare 4, 5, 6, or 4 and 6, I'm preparing 5 is an pontic. 7 is intact and it's in occlusion with the opposing tooth. Then I use a triple tray. If one more clinical situation I give you, if it's 5, 6, 7 are prepared and I'm going to do a triple tray impression. 8 should be there, 8 should be in occlusion. If 8 is not there and 8 not in occlusion, I do not use a triple tray, and I don't advise anybody to use a triple tray. So that means there is no tripodization. When I say tripodization, there should be contact here, there should be contact here, there should be contact on the distal aspect also. So that the in between these three tripod contact, you have to make impression. If there is no contact on the prepared surface, please do not use triple trace. And triple trace, your impression material overextending a triple trace, you cannot use triple trace for this patient. You have to really use your normal tray. Triple trace is not indicated here. And see here, the margins of the triple tray is exactly over your plastic, not even on the mesh portion of your tray. So all these errors we fail to visualize during our preparation and impression procedures. You want to be quite cautious here and always insist on flossing if it's going to be subgingival, and make impressions into the patient to minimize errors. And when checking for proximal contact, normally if it's not fitting, normally what the lab technician do is they'll slightly design your process slightly. They actually do a preparation on the adjacent to slightly, maybe 2 or 3 microns, so that it tight fits. Because it's very difficult to bring the what do you call that, baking errors, the ceramic errors. There'll be some shrinkage of the ceramic. It's very difficult to manage those shrinkage of ceramic while processing, while baking it. So they normally oversize it and they try to do it. So normally the marginal fit may not be there perfectly. So normally what you're supposed to do is you are supposed to interpose a shim stock or a thin carbon paper, right? Make sure that the mark is transferred and only trim that area. Don't blindly trimming everything. You have to know where exactly to trim. There's a hollow, just trim that. Maybe I'll show in the next picture. Trim there and slightly reduce it so that the processor fits perfectly in the oral cavity. Then if it fits, then you have to check for the margins. If it's not, margins are not exactly seating, then again, don't try to push it inside. You have to check whether the intaglation surface is perfect. So you keep a pressure indicating paste, or normally what I use is easily available in my light body. Load it like a cement and try to press it. Wherever there is an exposure of this, like this, on the light body, that means that area, the intaglation surface is not in contact with the, or it's more contact in the abutment tooth. So I have to trim the intaglation surface in this particular area, make sure that it smoothly sleeves into the oral cavity. And teach the patient how to close the mouth, not to bite. You have to teach. So being a dentist, we sometimes do not know how to bite. When you tell the patient to bite, they bite the opposite side. And it's a shear load, the ceramic will definitely fracture. Check all occlusions. And while checking also, you have to make sure that the patient doesn't bite it. Teach the biting normal way. So after cementation, after proximal evaluation and after seating the crown in its particular desired position, you have to check the occlusal surface for interference. If you see this particular picture here, after transfer of the articulating marks, if you see this particular picture here, you can see a blue mark, center is hollow. That means the articulating paper designed such a way that when you bite, the blue color dye gets dispersed towards the side. That means when the patient bites an articulating paper, the white mark is the interference, blue is the contact, because the area on the particular, the blue dye on the particular area get displaced to the side. So you have to make sure they trim only the hollow mark rather than trimming completely. So this takes a lot of time. This takes equal time as your preparation. So make sure that you don't damage occlusal morphology, do slowly, and make sure that you check occlusion in dynamic and centric lesion position, whatever the type of choice, polycarboxylate. I'm not a brand savvy. So the best material, that will give you a good idea in so many years of experience. This brand is good, that brand is good. Mix and match. But normally for all non-vital tooth, vital tooth, the patient's more compatible with sensitivity issues, then I go for your resin modified cements, or it's only a polycarboxylate. Glass enema is only on non-vital because it creates a lot of trouble later, sensitivity and all those other issues where it's very difficult to manage. Then after cementation, you have to make sure that you isolate between, you remove using a dental floss, remove the remnant cements. At the same time, the subpontic region, as if here in this provisional restoration, you have to insert the floss before cementation. Then once cementation, use a floss, run here and there so that the excess cement, whatever is there, comes out so that the subpontic inflammation is reduced. Then removal of excess cement in between area, just don't ignore it. And by doing so, it stays in the oral cavity for more period of time without much of trouble. Then next, the porcelain fracture. Porcelain fracture can happen in metal ceramic or all ceramic restoration. And if it's going to be metal ceramic, again, it can be within the ceramic itself or in the metal ceramic junction. The reason could be many, as I mentioned it before, the perforation in the metal where the ceramist has masked the perforation, that can lead to ceramic. Then whenever you give a metal ceramic restoration like this, you make sure that the ceramic or the facing, right, in the opposing to the next picture, I think I'll explain to you. Yes, here, if you see this picture, this is a metal substrate, this is a ceramic. When the opposing tooth crosses or when it guides, you make sure that the incisal surface of the opposing tooth, it's only on the metal or only on the ceramic. It should not cross the metal ceramic junction. If it crosses the metal ceramic junction, that means you tend to fracture that particular area. So when you do restoration, veneering restoration, make sure it's completely on ceramic or complete on metal. This opposing tooth should not cross metal ceramic junction. And any irregular sharp margins, or because again the technician here, what he'll do, will try to mimic the natural tooth when the patient has altered occlusal surface on the opposing side. It will be completely treated, but what you received is a full form of your occlusal form of your tooth. Those kind of things you'll encounter fracture when the patient bites like this. And the optimum thickness of your metal substrate should be not less than 0.3 millimeter. That's what the literature also says. Okay, just give me a minute's time. Dr. Matthew. I'm losing power. Just give me a minute's time. Okay, I'm sorry. So there are a lot of literature which says that you have to make sure that the optimum thickness is maintained for the substrate. And if it's going to be a failure within the ceramic, there are a lot of repair materials which it says that you can use silent bonding agent and use hybrid composites. But as a private practitioner, I really doubt this stays for more period of time. I've seen patients walking within 1 month or even a week after doing all this kind of repair procedures. The company claims, but it's not worked for me. If it's working for you, it's well and good. Likewise, if metal is exposed, you have to have an opaque layer, then followed by a repair composite. Again, the same. If it works for you, good. It doesn't work for me. And for causes for metal-free ceramic failure is going to be inadequate preparation like this, and preparation something like this, where your opposing tooth should be actually covering a portion of the prepared tooth. If this kind of preparation you have, where you can see a space between the opposing tooth here, do not go for a lithium disilicate or Emax crown, because that will end up in fracture when the patient bites. So you should have, because it's a glass ceramic, there is no support. So you should have a natural tooth or a tooth structure to support a glass ceramic. So if this kind of patients, if the preparation is extending till here, because the opposing tooth is covered, then I go for a glass ceramic. Otherwise, this tooth will be, the process will be fractured. Then you have connector failures because of many reasons. The connector design is not good here. If you see here, the connector design is not good here. Very thin, just to save money, right? And do not go with the technicians. Do not go with the market people. Say that zirconia stands. This is anterior 6-unit bridge where I replace the lateral incisor, right? Occlusion perfect, right? What I did, I just tried this in the patient's mouth for cementing. It fractured here. Right. So do not go by the market, get influenced by saying that you can give 3-unit bridge anteriors for your Emax crown. It doesn't work out. So it will be quite cautious. Individual crowns are okay, but don't go with them. And again, there are a lot of literature to support your zirconia crowns right now for up to 3-unit bridge. Again, it's a debatable subject where the literature, if you are favoring zirconia, then you can pick up articles saying that even 10-unit zirconia is better. If you're not favoring zirconia, you can find articles saying that even 3-unit zirconia is not better, not good. You understood, it's a double-sided, you get confused. So it's all in clinical exposure. What I do is more than 3-unit, high-impact zirconia, sintered, fine, I do it. 3-unit bridge. Anything beyond 3-unit, I do not go with zirconia because it doesn't have any flexural strength at all, it fractures. Then again, there's a classification for chipping of zirconia, how to manage. If the chipping of this is only on veneered zirconias, right? We have zirconia core where they veneer it. So grade 1 is where the fracture surface can be just polished and leave it, where the fracture surface can be repaired with the composite resin. Again, my doubts are there with respect to bonding between composite and zirconia. And severe chipping of zirconia, you have to repeat it. Simple. So these are 3 classifications reported in the International Journal of Plastic Dentistry in 2010. Then, if it's a fracture on the counter, you have to remove it and redo the entire processes. Again, this is all for lab. What normally it says is you have to make sure that the width, the entire width of this particular metal framework should be maintained while the fabrication, and this width on the posterior has to be minimum 2 to 3 millimeters, show that it doesn't fracture with this strength. And you cannot have designed something like this incorrect. So you should have one uniform pattern of your core pattern during fabrication. So by doing all those things, you encounter you reduce your errors and connector failures. Wear of restoration, using improper materials. This is, I think, people don't use it right now. Ardenal is a very old picture of mine where the patient walked in to show that the abrasiveness of enamel even wounds out the Ardenal. Then using your posteriors, long-time provisionals, right? How long? You cannot just leave your patients long like this for exposure of your adjacent tooth. And when I was talking initially, the veneering material, you cannot veneer. This is you understood? Can you see the ceramic in the metal substrate ends here? The veneering is on the natural tooth. You cannot have something like this. This should completely covered by ceramic. Sorry, covered by metal, over which you use other mechanical device, mechanical additions to bond your composites, right? So if you're not going to do like this, you will encounter this kind of issues. And sometimes inadequate control of occlusion also lead to restoration failure. So wear of restoration can lead to these kind of issues where it exposes the underlying tooth. Cement wash it, complete wash or cement, over eruption of the opposing tooth because the patient is tolerant, and over eruption of opposing tooth and dental caries. So if this kind of patient comes, you have to remove the perforated processes, do all the other corrections, make it conducive for using a 300 bridge, correct the occlusion, then redo the processes. And aesthetic failures, it can be color mismatch at the time of cementation, or the form of the tooth or the pontic at the time of cementation, and the gingival form here, as in this particular picture, in the time of cementation. All this can lead to some cementation aesthetic failure. As I mentioned, one picture here, there can be ceramic spillover of ceramic here. If you are going to something, this is in posterior, imagine this is an anterior. If you are going to see something like this and try to forcefully push into the patient's abutment, the ceramic can fracture at the time of cementation. So be cautious. And poor pontic placement. See, there are only one tooth missing here. There are two, we are replaced with 2 teeth. So this kind of issues, space management also can lead to failure. I just want to note this picture. This is a very old case of mine where the patient walked in with this, and this was maybe way back in 2000. I started my practice in 1998 or 99. So the patient walked in with an acrylic crown like this, right? And there are more number of pontics here. So I thought, okay, being a prosthodontist, I have to maintain strict rules and regulations. I gave this particular process to the patient. Optimum 6 crowns, and now the patient 6 in the processes. This is how the patient was looking anteriorly. 6, I think canine to canine. But if you see the patient's profile, my 6 unit and patient what was wearing the whole process, she was looking much better in that. So what you perceive will totally different. So you just cannot be a complete, as Dr. Kumar mentioned earlier, smile designing is not easy. You have to follow a lot of things. Don't take things for granted. And when you have patients something like this, why you bother? Be happy. And when they can tolerate this kind of aesthetic failures, sometimes they manage color failures also. And delayed aesthetic failure can be because of your periodontal issues or your gingival inflammation. In this situation, if you see the gingiva is completely delineated along with furcation environment due to some periodontal problem, right? These kind of things will lead to delayed aesthetic failure. Or sometimes bony resorption underneath your pontic region or subpontic region can lead to delayed aesthetic failure. So this kind of delayed aesthetic failure, the only one option is where you have to remove the processes, manage the existing situation, make sure that abutment, the entire working area is clean of all diseases, then you go for a new process. The second last is going to be a psychogenic failure, where if you're going to give this kind of processes, if you see this particular picture, there's one abutment here, This is what I know this is not an abutment. This is an abutment. So the entire process was staying with only 2 abutments, and patient was promised that it will stay rest of his life. Walked in with within 2 years, and I cannot call him a psychogenic origin because it's because of iatrogenic. He doesn't believe any doctor, and he says that we have done damage to him, and he's totally indifferent to you people, the operator. So do not do these kind of damages, induce these kind of damages by not following the textbook protocols. So, but if patient comes to you, you have to know first visit itself what the patient expectations are. Check the patient tolerance level to any treatment. Do not make the patient to sit for 5-6 hours in a dental chair and do some treatment. See, recently, just a month back, I encountered a trouble of full mouth rehabilitation, preparing for almost 6 hours with provisional maxilla and mandible, and patient walked in with a lot of ulcers and lip, everything was damaged. You understood? Then I had to put a sorry face in front of the patient. So you have to know the patient tolerance level, what the patient expecting, patient's financial status before you start a treatment. Just do not assume that the patient is going to pay. I normally know people don't do that, but you have to know. Patient will say a lot of things, Patkalan doctor will do, doctor, no, I manage. But when you say the real rate after you do something, then the issue starts. So all those things in the available tissue and the motivation level of the patient in accepting a treatment, you relate everything, you accumulate all this data before starting the treatment. Then you keep your fingers on the patient's mouth. Till then, do not touch any patient just for sake of doing treatment or just for making money. You end up in trouble later. And if a dentist later psychogenic failures, you have to see the sequence of old records, see what it is, and you have to, it all again depends on the ability of the dentist to manage. Again, the financial picture comes into role here, because patient spending so much money, again, you cannot ask the patient so much money, right? So you have to keep a lot of parameters into mind before promising anything. So last is going to be a maintenance failure. And as I mentioned before, you have to call the patient every 1 year, or once in every 6 months. And it's your job or your dental team's job to make sure they call the patient, evaluate the patient at that particular point of time, make a note of it. If you feel that there's some issue and you want to wait for some more time, call the patient again, do a thorough maintenance protocol with diet control, muscle exercises, and if it requires some full mouth cases where you have to give occlusal stabilization appliance, you have to do that and manage. And I began with Ponniyin Selvan PS. I'm going to end in PS. What PS means? Ponniyin Selvan? No. PS means permanent solution. Do you have permanent solution after seeing so many failures or management of failures in fixed partial denture? We are also trained in talking to the patient, saying that it's a fixed treatment or a removable treatment. We do not say, or we say the patient, whenever we relate fixed, we always patient imagine it's a permanent treatment. Or the patient comes to you and asks you, doctor, permanent kudunga. Doctor, can you give me permanent tooth? Right. So it's not our job to give a permanent. It's not possible to give a permanent solution. So let us change the terminology. Yeah, permanent solution. It can be a fixed definitive treatment. So whenever the patient walks in, when they ask for a permanent treatment or permanent solution, it's our job to tell them that we are going to give a fixed option, which is a definitive solution, which cannot be permanent, because none of the textbooks says that the fixed partial denture stays rest of one's life. We are saved by literature, but that failure should not happen within first 5 years or 8 years of time. If it happens, then it's definitely our mistake in not doing a good job to the so-called, right now, they are consumers, not patients. Then with this, I close my presentation, and I take this opportunity to thank everybody, especially the management, principal, and my dear good friend, Dr. C.A. Matthew, for allowing me to exceed my time by 20 minutes and giving some lecture. I rushed through my last couple of slides, or like the last 15-20 slides. Sorry for that. And thank you once again. Thanks, everybody. Thanks to the audience for listening to me. Thank you. I just fulfilled my what I intended to. Thank you so much.
Thank you so much, Dr. Anand. Wonderful presentation. Now, so many clinical tips that you have given, especially 2 things which I would agree to or keep constantly telling maybe the students also. One is regarding the process. As soon as it comes from lab, you should take the time, maybe if it's in a practice also, you should take the time to check that even before you call the patient, because it's quite embarrassment after you then he comes back after days, so which you could have solved by sending it to the lab. If you had observed that earlier, that's very important tip that everyone has to follow. And the second one regarding the radical decision on intentional root canal treatment and how much it could compromise on the strength of the abutment that you take. Unless and until it is surely indicated, don't go in for radical intentional root canal treatment. I totally agree with that. I think there are a couple of questions which are there. Dr. Mayavraj, can you put in the questions?
Yes, sir. Sir, one question from Dr. Vijay Lakshmi, which one will be a better one, either a fiber post or a metal post, sir? Is there any relationship between the modulus of elasticity between dentin and the material which we use, sir?
Correct. See, I very clearly told that if you have to have a good core, always you prefer a fiber post. But imagine there's more than 80% of the tooth structure is lost. And if you're going to use a fiber post and a composite core, which will not even support. So in those kind of situations where I give a cast post, right, and I go for a crown over that. And I make sure that the occlusion is also managed well, because in this kind of situation, if the occlusion is not managed well and extra load is going to be imparted onto the cast posted tooth, that cast post will act as a wedge and they split the tooth into two halves. So I normally, as I mentioned in the picture, 25 to 50% of tooth structure is present. You can go for composites, or above 25% is composite. Fiber is okay. Anything less than that, I always go for cast post.
Thank you, sir. Sir, one more question, sir. How will you differentiate between the high point and interference? How will you differentiate, sir?
What is the difference between these two? I thought both are same.
Question from the audience, sir.
No, I have to be elaborate. So I thought both are same. High point is otherwise called as interference. Or any Dr. Matthew, can you guide on this? Is there any, there are two different terminologies, or I thought both interference, high point, both are same? No.
Yeah, I think maybe relatively, if you see it is the same. Unless maybe if you compare it in centric or eccentric, no.
Okay.
Really seeing,
Okay.
yeah.
Okay. So with your shim stocks or articulating papers. Okay, actually I had a couple of slides on that also. I just removed it before I presented. Maybe around 12 slides I had on how to check for your occlusion, dynamic occlusion, centric occlusion, what type of shim stock used to use all for this kind of processes, right? So simple, if it's a white, if it's in hollow when using articulating paper, it all works on the dispersion of the dye material. So you have to prepare only the hollow on the same inclines of where it's been felt or where it's seen, instead of rather trimming the entire occlusal surface. Okay. So first, normally when I insert, I have to make sure that there is maximum intercuspation or the patient's existing occlusion in position. For example, if the patient walks in with canine guide occlusion or maximum intercuspation, I will maintain only the maximum intercuspation position what the patient had. That means before starting the treatment, I have to evaluate what was the occlusion on the opposite side. After giving my processes, I will make sure that the same contralateral side occlusion is maintained. Then I check for dynamic occlusion. When I say dynamic, again, I always prefer a canine guided, otherwise a group function occlusion. I will make sure that my processes does not guide the mandible of the patient. It has to be the patient's natural tooth. If canine is involved, you have to have a canine group function occlusion.
Sir, two more questions, sir. How to manage a finish line recession case, sir? It's
going to be knife edge, vertical preparation, simple. Only option is there. Most of the root canal treatment tooth on the proximal side, what we do, it's not possible. If you're going to get a finish line there, it's going to be over prepared. So it will be only a knife edge finish line.
Sir, one more question, sir. For permanent cementation of the process in vital teeth, which cement would be preferable, sir?
It's not permanent cementation. Again, I stay correct. It's definitive cementation. I use for vital tooth, I use only, to be very frank, don't laugh at me, I use polycarboxylate. And if the crown structure is not good, then I go for resin modified. When I say crown structure is not good, there should be some optimum retention resistance form from the abutment as such. If the abutment crown is hardly 2-3 millimeters, then I think that if I feel that the cement should take more role, then I use resin modified. Otherwise, most of my vital tooth is zinc polycarboxylate, and you can use resin modified also.
Thank you, sir. Any questions from the audience, sir?
Any more questions from the audience? No, even if it is for Dr. Kumar, in case there are any questions, you could go ahead. Okay, I think there are no more questions. Then maybe we could end the session. But before we end this session, we would like to do the a small valedictory function by giving the certificates of appreciation. So this is Dr. Anand. This is the certificate of appreciation for you. Please do accept it.
Thank you so much, Dr. Matthew.
Yes, we
And
will be sending it through the email too.
Thank you so much.
Yes. Dr. Kumar, this is your certificate of appreciation. Please do accept it.
Sure, sir. It's my pleasure.
Thank you. Thanks. Big thanks to both of you. Thank you so much.
Matthew. Pleasure
Yes,
sharing this. Thank you.
we have a small vote of thanks also, which is there.
So I myself, Dr. Maheshwaran, sir. I'm here for the vote of thanks. On behalf of Department of Prosthodontics and KSRIDSR Institute of Dental Science, I would like to thank the management and the principal for giving this opportunity to conduct this CDE program. And we are really thankful to the both speakers, Dr. Anand sir and Dr. Hanuman Chalapati Kumar sir. Thank you so much, sir, for this wonderful presentation. I thank all the participants, the faculty members, the postgraduates, and other teaching and non-teaching members of our department. And I once again thank everyone for this CDE program. Thank you, sir.
Okay, nice seeing you, Mahesh. I never thought that you are there. Good to see you, man.
Thank you, sir.
So then to the participants, to all the participants, I do request you to respond to the post-test questions and the feedback which is sent. I think that's quite mandatory before we send the certificates to you. So please do respond. It will come to your mail. Both of them will come to your mail. Please do respond. So shall we end the session here? Can we leave?
Thank you so much.
Sure.
Thank you. Thank you.
Thank you, everybody there. Thanks, everybody.
Thanks to all the participants.